Sir, we are live on YouTube.
Just a second, sir. Just a second. We are just going to be live on YouTube.
Audio hearing. Thank you.
Sir, we are live on YouTube. We can start.
Okay. Good afternoon, doctor. I am Dr. Vishal Vahane and working as a senior medical advisor at Walter Bushnell. At the outset, Walter Bushnell thanks Barodara Ops and Gynec Society for giving the opportunity to organize this webinar. On the behalf of the company, I welcome the expert faculty, speaker, panelists, and all attendees for the webinar on enlightening the two white pearls of reproduction. I would not add too much and briefly introduce Dr. Deepa Pitre. She is the Associate Professor at GMRS Medical College. She has done her fellowship in IVS and gynec endoscopy. She is the current secretary of Barodara Ops and Gynec Society. Madam is working round the clock for the COVID patient, and we are privileged to have Madam for today. So I request Madam to start with the session.
Thank you, Dr. Vishal. So a very good afternoon to everyone. With soaring mercury levels and the challenges of pandemic refusing to die down, life has definitely taken a toll on all of us. But someone has rightly said, live as if you were to die tomorrow and learn as if you were to live forever. So taking the quest for academic excellence ahead, and without wasting much time, with such eminent speakers on our desk and a very good panel here, I would carry forward the session by saying that the two enlightened pearls are the most precious possession a woman can have, and she's defined by them. So I'm handing over the session to the Master of Ceremonies today, Dr. Amita Shah, Madam, who is a senior obstetrician working in Baroda, and also the Vice President of the Baroda Obs and Gynec Society, and Dr. Dolly Gupta, the Treasurer of Baroda Obs and Gynec Society, and an Associate Professor at Gotri Medical College. So over to you, Dr. Amita.
Yes, thank you, Dr. Deepa, for the very good words. A eagerly awaited and a power-packed academic session by a very eminent and renowned speaker is going to be started soon. And I'm very sure we are all going to get great insights from their talk and a very precise and clear-cut take-home messages. There is no doubt that it is going to be a great academic feast, and along with a brainstorming quiz also. Now, let the ball start rolling. Suppose if we start with our academic session, I would like to invite our worthy chairpersons for this academic session, Dr. Sir R.G. Patel, who is the director of the Sunflower Women's Hospital, Ahmedabad, senior and renowned infertility specialist since many years. The second chairperson is Dr. Manish Pandya, who is also a very senior doctor and professor and head of the department of Surendranagar Medical College. And his area of interest especially is endoscopy and infertility. Now I would invite and will to chairperson to start the session, please.
Good afternoon, everybody.
Good afternoon. Yes, Manish. Hello, Kanti Bansal, madam.
Yes.
At the outs, happy to see on a digital platform in this pandemic situation to learn many things. At the outset, I thanks to Baroda OBGY Society, very academic, very dynamic. I am very pleased to introduce my dear friend Kanti Bansal, my good friend, great human being, very charming, very dynamic. She is from my city only, Ahmedabad, is a senior IVF specialist from Safal Institute. He is pioneer for the IVF and many first in her name. He's awarded very prestigious RCOG medals. President Gujarat ISAR chapter, I have worked with him, with her for the 2 years. Many programs we have done, and very successful. We have done 2 years of academic activity. Among UA ISAR was the highest presence ever. That was a great achievement with Kanti Bansal madam. He has published many books related to infertility, PCOD and endometriosis. She is editor of European Journal of Endometriosis. She is National Advisory Board of Indian Journal of Human Reproduction Sciences and founder chairperson of the Endometriosis Committee of the FOXI. So it's my pleasure to introduce my dear friend. She will talk on intractable ovary management. We know everybody wants good outcome in infertility by simple treatment, by IUI or IVF. So today is very interesting subject. We learn so many things from our esteemed speakers. Over to Kanti Bansal madam.
Thank you so much, Dr. Archie. In fact, I used to call him when I was the president and he was my secretary. I used to call him Raja, not Archie. And before that, thank you so much, my dear, beautiful friend, Archana, that's Archu, and also the entire Baroda Obstetrics and Gynec Society. I would also not miss this opportunity to thank my another very good friend who doesn't know him, Dr. Jatin Shah, and actually he is the biggest pearl in this, the two ovaries have become very small pearls in front of this big pearl. Thank you so much, Jatin, for being here. And let me share my screen, please. Yeah, so now thank you again, Baroda team, for allowing me to have my own topic, and very exciting topic, I must say. This is managing intractable ovaries. Now, let me tell you all must be wondering what is intractable. Intractable means stubborn, means, the piggy-headed people, or that's how I can make you understand, or to be more easier to understand, like the stubborn husbands or the spouses. So how to tame them is my topic today. How not to tame the spouses but the ovaries. So I feel a great deal of what is presumed to be interactable or inevitable in this world doesn't strike me that way at all. So nothing is impossible. We can really treat them and make them work. So now what is ovarian desensitization? Actually, when in the polycystic ovaries, basically I am talking of the polycystic ovaries and related to infertility. So in this scenario, the ovaries are hyperactive. There are multiple small follicles, and then what happens is there's a lot of ovarian activity. So what we want to do is bring them at the same par with normoandrogenic and normoestrogenic state. So what will happen once they are normal, they will respond to the ovulogens, maybe letrozole, maybe clomiphene or gonadotropins. But please understand that it is not just the same protocol for all. It is a very individualized protocol, or it is a tailor-made. So now this is a very a sort of a complicated table that I have made, but please don't worry, it is not at all so complicated. If anybody wants to have this table from you, just write to me and I'll mail it to you all. There are 6 different classifications that are there, and these are really based on the somatic and endocrinological assessment, also the sonographical assessment, and based on these different parameters, we class them, and then accordingly we have the treatment. Like for instance, here you can see class 1, we have ovulation induction and laparoscopic ovarian drilling. So what I have made, I've simplified one by one and make it very, very clear for you all. Now the first class is the polycystic ovaries. These polycystic ovaries, this class is nearly normoandrogenic, normoestrogenic. These are non-obese, but they do have an ovulation. So what do? We just give them pre-treatment with oral contraceptive pills, that is the cyclic oral contraceptive pills. And so what happens is the ovulation rates will increase and pregnancy rates also increase. How do the COCs really help? What they do is they will suppress the serum and ovarian androgen levels. So now we know that in PCOS, we have a lot of value when we give these combined oral contraceptive pills, because they definitely increase the implantation and pregnancy rates, and also they decrease the so they also decrease the miscarriage. Sorry for that. And one more benefit is the incidence of small for gestational age infants is also decreased. Now the second one is the second classification is the PCOD. PCOD is polycystic ovarian disease. Here hyperandrogenic, relatively obese, oligoamenorrhea, anovulation is there. The endocrinological profile is that the LH is high, and there's alteration in the LH-FSH ratio as well. Testosterone is high. So what do we do in these cases? We have to reduce the weight and give insulin sensitizers. Now then what I have done is I have combined class 2 and class 3. Class 3, it's a hyperinsulinemia, because the treatment as such is the same. We will have to use the insulin sensitizers. So in class 3, we have once again hyperandrogenic, relatively obese, oligoamenorrhea, anovulation. And we also have raised insulin levels and insulin resistance. Here again, we need to decrease the weight of the patients and give insulin sensitizers. Now, we know that lifestyle intervention or management is very, very important when we come with the patients of PCOS, especially the second and third classification, where the patients' BMI is increased and they are obese. So before any intervention, we have to give them this advanced management of lifestyle modification. We have to make them understand that two important things: the diet. The diet has to be hypocaloric, exercise has to be long term. Generally, I tell my patients, they ask me, till when do we give the, when do we have to exercise? I tell them till you die. It's very harsh, but we need to make them understand about the long-term complications as well. It's not only the babies we are giving them, but also their whole health system is important for us. And when they reduce around 5 to 10% of the body weight, it is quite all right. Other things like, just leaving on alcohol and quitting smoking is also very important. And in case you feel, you can also refer them to good nutritionists and also for physiotherapy or other assistance. Sometimes the PCOS patients are so depressed, you may also send them to a psychiatrist if necessary for depression, etc. Now, this is something which I really like. Name itself is SMART. This is the effectiveness of lifestyle intervention. SMART means these interventions have to be specific, measurable, achievable, realistic, and timely. So we have to give them a goal setting and self-monitoring programs. And when you say realistic, means they should like it. If they like these things, these activities, they'll continue to do it. Otherwise, they'll leave halfway. Or some women are there who don't like to continuously do one work. So they will go on changing. You can tell them, okay, there's no problem as far as you like it and you continue it. And So all our interactions and reactions of the doctor should be patient-centered, not what we like. Patients should like. If they like to do dancing, let them dance and lose their weight. So we have to value, women's individualized health lifestyle preferences, their cultural, socio-economic, and ethnic differences. So that way we have to promote, even the doctor has to be smart and give this smart effectiveness of lifestyle. Now, what about bariatric surgery? We have seen patients with BMI 35, want to have a baby. So can we give them bariatric? We should try other methods to reduce their weight, because this is still taught as experimental therapy, and we have to really see what is the risk to benefit ratios till we adopt this sort of therapy for fertility. Now coming to a major bulk of the treatment that we do to our patients, we all are using insulin sensitizers left and right. Most important molecule, the pyruvanides, and in that metformin is the master of the molecule as far as insulin sensitizers is concerned. We should know in and out of metformin. Then there are a very small proportion of patients where metformin they cannot tolerate, and for these patients, out of the thiazolidinides, we can give them pioglitazone, keeping in mind the fluid retention, etc. And last but not the least in the list is the myoinositol and dichloroinositol. Myoinositol is now used in a big way, and I also second that because it has given very good results in my center, which has a specialized PCOS clinic. Now, how do these act? They directly act, they do the hepatic glucogenesis, peripheral glucose uptake, and other, insulin, they act upon the insulin. So then what happens is a decrease in the insulin, and then that gives rise to a decrease in the androgen levels. And then because the androgens are decreased in this second and third classification, the fertility rates are increased. So now a little bit of metformin. What happened to metformin and what's happening to metformin? There's a rise and fall of metformin. Initially, there was a big rise in metformin use whenever something is very new. It happens that way, that everybody starts using, and then there is a fall of use of metformin, and again we have come back to using metformin very appropriately, and there are many literature supporting this. There's a Cochrane database also. Now let me tell you how we can use in the most appropriate way. The current status, metformin is not indicated as a primary ovulation induction drug in PCOS. Combination with clomipene superior or over clomipene or metformin alone should not be really used as ovulation induction. But when you combine with letrozole or clomipene, it has a lot of increased pregnancy rates. And the best thing that happens in PCOS patients is that the incidence of OHSS, ovarian hyperstimulation syndrome, reduces with the use of metformin. What's the treatment regimen? It's very simple, but before we start, we have to confirm normal renal and liver function, and then start. You should start with the lowest dose, and then you can go on increasing. What I do is I just give half a dose starting from 250 milligrams, and then gradually increase this. And if the patient is, generally it is around 1,500 milligrams per day, divided doses. But if the patient is very obese, then you can also give up to 2 grams. At least you should give minimum 8 weeks to 12 weeks for the right way the patient performs when we do the induction of ovulation. That is the reason I am telling that you should give for a longer duration. There are side effects like diarrhea, nausea, anorexia, abdominal bloating, lactic acidosis. Now coming to myoinositol, this is a novel method for ovulation induction. Dose is 2 grams per day and do the ovulation rates. Here the duration is again 12 to 14 weeks and the real dosage is 4 grams and better ovulation rate is there. It decreases the body mass index and the lipid profile. Now, how does this myoinositol act? It really, all the parameters are restored, like the hyperinsulinemia, it increases the insulin sensitivity, improved glucose utilization, improves the pregnancy live birth, and there are many other benefits of using myoinositol. There are many literature. I won't go into the details, but starting from 2008 to 2012, 13, and up to 2014 and 17, the literature goes on up till today. We are getting a lot of interesting, good reference for myoinositol. And so ultimately we can conclude that it's a very effective and well-tolerated option for women, and it decreases the insulin receptivity and weight loss and high conception probability. So when we compare myoinositol with metformin, there are studies which show that myoinositol is better when they compare for the ovulation rates, the IMS inhibiting, how it is reduced immediately, the side effects are less, and also there's no malabsorption of vitamin B12. Now, I also give combination of metformin and myoinositol, and I've seen very good results with this combination as well. Now, N-acetylcysteine, this is a mucolytic agent, and it improves the insulin resistance. Adjuvant therapy along with the letrozole and clomipene, and there's many studies again which shows that N-acetylcysteine increases the ovulation and pregnancy rates. Now we come to the fourth classification, that is the hypertrichosis. Here we have high testosterone, insulin resistance, acanthosis nigricans, ovarian hypertrichosis, and so GnRH downregulation has to be done when we use HMG in these cases of hypertrichosis, where all other ovulation induction drugs do not really work. So we have basically 3 protocols, but whenever these days there's a lot of improvement in the protocols, especially for the PCOS patients. When we are doing the IVF for our patients, we generally use the antagonist protocol. Now, some of the regimes of gonadotropin therapy for the regular ovulation induction, please do not remember anything else except the chronic low dose protocol. That is the only one very good for our PCOS patient when we just do ovulation induction or IUI for these patients. And here what happens is we aim to reach the threshold FSH concentration very, very gradually. And so what happens, the explosive ovarian response is avoided, and this is very typical for PCOS patients. Now this is just a schematic representation where we, if it is HMG, we start with 75. If it is recombinant, we just have to take around 50 or 25 also. Just monitoring is very important. Every 2 to 3 days, it is hectic, but it is worth it. Once the follicle starts growing, then you don't have to increase the the dose. But if it doesn't increase for about 12 days, then you double the dose and then again continue monitoring till the follicle becomes 18 mm. Now we come to the class 5. This is hyperprolactinemia. Here the prolactin levels are very high, and the patient has dopaminergic state. So here we give cabergoline 0.25 milligram twice a week for 3 months. But if we have to see for 1 month, if it does not really respond, then we need to increase the dose to 0.5. Maximum dose that we can increase is 1 milligram, 1 gram. Now class 6, that is high DHEA, we have to use dexamethasone. It acts directly Dose is low dose. Actually, you should just remember you have to use a low dose to prevent complications. And indications are when DHEA levels are very greater than 39 microgram per DL, and it may reduce anti-estrogenic effect of clomifene as well. And this dexamethasone has 40 times the glucocorticoid effect of cortisol. And so daily dose greater than 0.5 milligram every evening should be avoided to prevent, as I already told you, risk of adrenal suppression and severe side effects that resemble Cushing's syndrome. Now, there are several regimens: long continuous, long alternate days, and short. Long continuous is 0.5 milligram daily, but you have to check regarding the cortisol level. If it is more than 2, then you have to reduce the dose. Then long alternate days also you can give, but as I told you earlier, please give short, protocol where 0.5 milligram days 5 to 9 of the cycle, or 2 milligram days 3 to 12. These are the various protocols, or 2 milligrams 5 to 14. Now, complications, most undesirable effect is the weight gain. And if 0.5 milligram dexamethasone or 5 milligram prednisolone per day were used for less than 3 weeks, complications are rare. That's what I have been stressing at point, and it can be stopped abruptly. Now, a little bit of laparoscopic ovarian drilling. It achieves unifollicular ovulation, no risk of OHSS, alternate to gonadotropin therapy for CC-resistant anovulatory PCOS. So what happens, mechanism is that it releases the androgen by drilling, rich follicular fluid, and decreases the androgen producing stroma. Also, there's a transient reduction in inhibin and precipitous fall in the LH. That's what we want in these PCOS patients. The very important factor is that the crowding that is there of the cortex. Many people suggest that if the cortical material is too much on sonography, cortex is thickened, then also LOD is indicated. So that crowding will decrease. Then I won't go into the details of surgical techniques, but I can tell you that some surgeons really think that the number of punctures depends on the size of the ovary, but most of the surgeons believe in that 4 factor, 4 punctures ovary, 40 wards, and all the other things that laparoscopic surgeons believe in the factor 4. And the last very important point is that despite lack of convincing evidence and significant reduction in operative time, most still perform bilateral over unilateral drilling. So this is a thought-provoking message that I have given you all. Why should we do that? Now, should we be doing re-drilling? There's not a lot of RTCs for this. So till then, we should not be doing second re-drilling laparoscopic surgery, because it could again give rise to a lot of additions and also decrease the ovarian reserve. Now, what are the advances in laparoscopic ovarian drilling? It's not the same old thing what we're doing, but we can use it, do it by monopolar hook electrode, harmonic scalpel. Obvious laparoscopic ovarian drilling is proposed. Then we have recently the transvaginal hydrolaparoscopy, that is the fertiloscopy. Very interesting. I am very interested in the transvaginal sonography intervention. So this is, I think, really very interesting. Transvaginal sonography guided ovarian interstitial laser treatment are now being developed, and hopefully we'll be doing it very soon. So, dear friends, here I come to the end of my very exciting topic, to tame these ovaries and to make them respond to all the ovulation induction programs that we give them. And what I could say at the end is every patient tells a story. So these are a few of my books. If anybody is interested, write to me. I can procure them for you all. Thank you once again, Baroda, and all my dear friends here, Manish, Archie, Jatin, and all, Juhi, and all others who are viewing this program. Congratulations, Archana. I know you're going to do wonders during your tenure. Thank you so much.
Thank you, Kanti Ben. It's a wonderful presentation, as always. You had rightly said, in PCOD or intractable ovaries, one thing is mastered, that is exercise, exercise and exercise. Just Vidya Balan is saying entertainment, entertainment and entertainment. So we have to advise our patient to go for exercise. And you have done roller coaster job of metformin, myoinositol, N-acetylcysteine, Dexona, everything you have done. But lastly, I love the laparoscopic ovarian drilling, because as a laparoscopic person, my first thing is to do ovarian drilling, rather than going and wasting my time for 3 to 6 months by giving myoinositol and metformin. But this is also, yes, I want to say controversies. Yes, madam. But I think medicine is also has a very good role. And myoinositol, you told madam, 2 gram with combination of N-acetylcysteine gives fantastic result, and each and every patient doesn't require laparoscopy, but laparoscopy has got its own advantage. So thank you very much, madam. Archana madam, we would like to take questions after 2 sessions over.
Yeah.
Yes, sir.
Yes.
Okay.
Okay.
So,
just to interrupt,
yes, madam.
Now, I would like to invite Dr. Ashish, our quiz master,
Yes,
to flash the certain questions in the quiz. Then again, we will take the second speaker, sir.
Okay, madam. Okay, madam. As you wish.
Yes, Dr. Ashish, please.
Welcome, Ashish.
Thank you. Just sharing my screen.
Yes, yes, Ashish.
To begin with, I would like to thank the Baroda OBGYN Society for giving me this opportunity. And it's indeed a pleasure to bring in questions immediately after the talk of the pioneer in the field, Dr. Kanti Bansal. So, madam, thank you. And the quiz is going to be in 2 parts. I'm going to have 5 questions now and 5 questions after the second talk. And we will declare the results at the end of the panel. And there are 3 prizes declared for this quiz at the end of the entire panel. Before I proceed, I would just like to say one thing, that the questions that I've framed are sort of a mix of the medical knowledge and the general knowledge in the field of PCOS. And with that, I would like to focus on the simple rules to answer the questions. Each question would have a 1 word or a few words answer. So whenever you are answering, answer the question number along with the answer so that we understand to which question you are answering. Secondly, answers given within 1 minute of flashing the question will only be considered valid answers, because you cannot have indefinite time to keep on answering. Answers can be sent only by WhatsApp to one of the following numbers by WhatsApp messages only. That is my number, that is 8849450012, or Dr. Deepa's number 9825569008. I request everybody to save these numbers and keep your WhatsApps open so that you can immediately start answering the questions which are going to come in the next slide. Also, initially we said that we'll be allowing through the chat box, but chat box doesn't have an option of individual answers. That means directed to an individual person. It's a generalized chat box. So answers sent in the general chat box or by any other means will not become valid answers. So you will have to answer by WhatsApp to one of us. And please mention your name to begin with the first question so that we know who is answering to that question. I hope I am clear to everybody, and let's have some fun, right? Satisfaction lies in the effort, not in the attainment. Full effort is full victory. That's what Mahatma Gandhi has said. So our purpose is not that everybody should win. Our purpose is to apply our minds and get involved. So friends, let's quiz. Here is a question 1 coming to your way. Which dermatological manifestation of PCOS is shown in this picture? We'll be allowing 1 minute. Nobody would speak the answer, only the WhatsApp answers. And Dr. Deepa is going to guide me once the 1 minute time is over, and then I will move to the next question. So which dermatological manifestation of PCOS is shown in this picture? That is a question. question number 1. Dr. Deepa, please let me know when 1 minute is over.
Yes, yes.
Answers have started pouring in, and I'm so happy that.
Next question, please. Next question, please.
Second question. As per the available literature, this person has first described the histology, but not the treatment of polycystic ovary. Who is he? The name of the person. So this person is first described the histology, but not the treatment of PCO. Who is he? So this question is related to the history of polycystic ovaries, and you can try to answer this question as well. I'm waiting for Dr. Deepa's note to tell me that when 1 minute is over. So the name of the scientist is the question here.
Next question, please.
So the third question comes your way. Which month is celebrated as PCOS Awareness Month globally? We're doing a lot for awareness of PCOS, but internationally now we are celebrating a month. Entire month is given to the awareness of PCOS, as we know that it's a lifelong disease, ranging from the adolescents to the elderly age group. And so there is a PCOS Awareness Month. Which month is that? So answers are really pouring in, and I'm so happy that everybody is actively involved. This is a picture taken from one such celebration during that month. And there is a PCOS challenge group internationally who has organized this event.
Next question, please.
So coming to fourth question, this is a picture of a library named after Robert Benjamin Greenblatt at Georgia Health Science University, Augusta. In 1961, he achieved a breakthrough in one of the aspects of medical management of PCOS. What was this breakthrough? In the inset picture, you can see Robert Benjamin Greenblatt, who has done some breakthrough invention in the medical management of PCOS. What was this breakthrough? What did he invent? So the fourth question is, what did Robert Benjamin Greenblatt invent as regards medical management of PCOS?
Next question, please.
Okay, so we are moving to the last question of this half, that is question 5. What is the male equivalent of PCOS described as? What is the male equivalent of PCOS described as? There are subtle clues given here. Maybe you can pick those clues. I have tried to keep visuals in all the questions so that the quiz remains interesting.
Yeah, time up for this.
So I'm signing off as of now, and I'll get back to you after the second talk. Thank you so much, organizers, for giving me the opportunity.
Thank you, Ashish. Indeed, a brainstorming quiz. Thank you for doing that for us. Over to chairpersons again.
Thank you, Ashish, for the last just Bala. So thank you, Baroda OBGY Society, for giving me opportunity. Thank you, Kantiben. Thank you, Archana, for giving me chance to introduce my big B, Jatin P. Shah. Jatin has specialized in IVF since 1991 to 2023. You see, 30 years experience. And within that 30 years, Jatin Bhai has delivered more than 18,000 babies. Bravo, Jatin Bhai. Hats off to you. He is not only the field of IVF, he had written a co-author, Gantiben. There is a very good book of Atlas of Gynecological Surgery that is co-authored by Jatin Bhai. Jatin Bhai is gold medalist from Bombay University. He is director of Mumbai IVF Center. And recently he has done two good study in the field of IVF, that is use of GCF and use of progesterone. That is his original research paper. Jatin has got so many things. First in freezing, first in ICSI, first in this. He was a member of first team of Indira Ben, who has performed the first IVF baby in India. Apart from this, Jatin Bhai is very good photographer and, believe me, very good singer. He can sing in both male and female voice. So nowadays, Jatin Bhai, every time we can say that dais is yours, stage is yours, podium is yours. Now I say this slot is yours. So utilize your slot and give us, enlighten us with the IUNI, not this is IUI, intrauterine insemination. Thank you, Jatin Bhai. Now slot is yours.
Thank you so much, dearest Manish. At the outset, of course, a big thank you to my dear friend, Dr. Kanti Bansal, who invited me for today's program. And of course, I'd like to thank the Baroda OBGYN Society too. I totally agree with Dr. R.G. Patel when he said that Kanti is a really outstanding human being. She has a real heart of gold, and I experienced this again a couple of weeks ago when one of my dear family friends was looking out for a COVID bed in Ahmedabad, and we were really struggling, and I just called her, and within a couple of hours, she helped him, and the gentleman has come back home yesterday, and he's full of gratitude for her, although she doesn't even know him. So thank you once again, Kanti. Dearest Manish, R.G. Patel, Dr. Sushma, Dr. Amita, Dr. Deepa, Dr. Archana, pardon me if I forget some names, but all the organizers putting together today's show. It's a pleasure again, and let's begin with then how should you go about stimulating the ovaries when you are doing an IUI. We heard a brilliant talk by Kanti about how you should go about managing PCOS with the lifestyle management, drugs and exercise and all those things. And now let's get down to actual clinical practice. What do you do when the patient comes to you for having a child? So when we begin with ovarian stimulation, you must remember that when we look at the 10 commandments of what gives you an IUI success, of course, young age, AMH, good sperm quality, good semen preparation, all that is all known to everybody. But probably the most important of the 10 commandments is a good controlled ovarian stimulation. And here I want to set right, because a lot of people take IUI very casually, and that is when you don't get good success rates. And then you feel, oh, IUI is just not good enough and it doesn't work and it's not a good treatment. So remember, try to take young patients, of course, patients who are capable of spontaneous or induced ovulation and have a normal ovarian reserve, at least one patent fallopian tube with a good, healthy embryo-ovarian relationship, an easily negotiable cervical canal, and a sperm count, at least a total progressive motile sperm count after a good sperm wash, even in a male infertility patient of at least 1 million, if not more than 5 million per ml. Don't do an IUI for every infertile couple who walks into your clinic. Remember, the most successful categories and the commonest categories you will get are the PCO groups, the anovulatory infertility, where OI cycles with timed intercourse have failed to give a result. And you have your mild endometriosis where you've done a good surgery, but still she hasn't conceived. And of course, the major chunk would also be unexplained infertility, where you feel that, okay, she's tried enough, nature has been given a good chance, and now it's time to move on to more being a little more aggressive with maybe ART such as IUI, IVF or ICSI. For male factor, again, I'll come to that slide later on also, that there should be a cutoff below which IUI is not really successful for male factor infertility. So remember, when we talk of controlled ovarian stimulation in IUI, it is different from IVF. In IVF, we are targeting 20, 25, even 30 oocytes. In IUI, we don't want more than 2, 3, or maximum 4 good quality follicles and oocytes so that you don't have a very high order multiple pregnancy. You want a uniform cohort. You don't want a premature LH surge or luteinization or LUF or a cyst formation. You definitely don't want hyperstimulation. You want to keep it cost effective. You want a good endometrium, and you want a reasonably good take-home baby rate. So to get this right, first you need to categorize the patient. Half the battle is first identifying that what type of patient this is and what would be the best protocol for this patient. For that, you take into consideration the age, the BMI, her previous response to treatment, if any, her AMH level, the AFC level, is there any associated PCO or endometriosis? And then you will categorize this patient as one of 3 categories, that either she is a high responder, the classical PCOS or anovulatory, either she is a normal responder, which is most of your unexplained infertility patients, or she is the low diminished ovarian reserve patient or the poor responder. And for each of these 3, you need a different selection of ovarian stimulation protocols. So let's begin with the PCO and the high responder category. Of course, our classical good old clomiphene citrate, all of us have been using it for ever since we started our practices. We know that in an anovulatory patient, whether you start on day 2, 3, 4, 5, it's the same. Since most of them have already done some cycles before coming to you with ovulation induction, you could start directly with a dose of 100 milligrams, which seems to be more ideal than 50 or even 150. And please remember that don't go on doing the same thing month after month after month. And remember that 75% of pregnancies which are to be achieved with clomiphene are usually within the first 2 or maximum of 3 cycles. As you can see here, 50% of the pregnancies which are to occur will be in the first cycle, another 15% in the second cycle, and very few after the third cycle. At what size should you give HCG? Nothing much to worry here. Whether you give it at 18, at 20, or even 22, your pregnancy rates will almost be the same when you are using CC exclusively without any additional HMG or any other adjuncts. Then you can give HCG at any of these follicular diameters. Of course, the biggest drawback with clomiphene was its direct anti-estrogenic effect on the endometrium. And you can see here that the better the endometrium, obviously you have higher clinical pregnancy rate. But what I'm trying to show is that even at 7 millimeters, the pregnancy rate is not 0. So we now have evidence that you don't have to cancel a cycle. I will also show you another trick if there is asynchrony between the follicular size and the endometrial thickness in a clomiphene cycle when we talk about the triggering. So what happened? And that is when we had the introduction of aromatase inhibitors, and Legros, of course, solved it for us in 2013 when he showed that letrozole should be first-line treatment for PCO patients when you're considering an IUI, and you will have a 44% increase in pregnancy rate as compared to clomiphene citrate. And of course, corroborated by a lot of other studies subsequently. And you can see in 2017, patients receiving letrozole achieved a significantly higher clinical pregnancy rate at 60% compared to about 40% with clomiphene citrate. So no two arguments here anymore. We know that for the anovulatory PCOS patients, maybe, or of course, definitely, letrozole is a better first-line treatment. Another protocol which I have been commonly using is a combination. You get the benefits of both clomiphene and letrozole. That means you give 2.5 of letrozole and 50 mg of clomiphene from days 3 to 7, and then go ahead with the cycle. And you can see in intrauterine insemination, you can see patients who received letrozole and clomiphene had a statistically higher ovulation rate of as much as 77% versus 43% if any one of or letrozole alone was used. So a lot of you could try this out in your practice and hope to get a higher ovulation rate. If clomiphene or letrozole don't give you a result in the first cycle, subsequently in the second cycle, I move on to a sequential protocol, which is addition of HMG. So you will give letrozole from day 2 to 6, usually 5 milligrams a day, then add HMG 75 or 112.5 or 150 as per the BMI and the response from the last day of the clomiphene or letrozole, and then go ahead with HCG when your follicles touch 18 millimeters in mean diameter. Now here, don't postpone to 20 or 21, because the minute you give HMG, you will have higher estradiol levels, and you might trigger off a premature LH surge if you are not adding the antagonist. Again, for the high responders, letrozole HMG combination better than the clomiphene HMG combination. You can see double the pregnancy rate at 26% versus 13% with clomiphene when you use letrozole. And this is obviously because of a better effect on the endometrium as compared to clomiphene when you use sequential protocols. And as this study in 2015 again showed, that when you're talking of sequential CCHMG or letrozole HMG protocols, you have a lower incidence of LUF, thicker endometrium, and higher pregnancy rates when you use letrozole as compared to clomiphene. What about gonadotropins for this category? And here everyone is a bit scared because of the dreaded hyperstimulation. So the most important thing you should do now for these patients is, you know, you will be starting with a low dose, and yet if she hyperstimulates, what are you going to do? So when you start giving gonadotropins to a PCO patient, you must counsel them for two eventualities. One, that if she cannot afford or if she is not willing, then to convert to an IVF, you would have no other option but to cancel the cycle, because you cannot take a risk with hyperstimulation. But you have to try and convince her that it would be better that we convert to IVF, because even in the future, whenever you take gonadotropins, you will have a similar response, and we can't keep canceling cycles again and again. So you talk to your neighborhood IVF center and easily convert the IUI to an IVF and expect a reasonably good pregnancy rate here too. If you do this counseling before you give the first injection, you will really see a very good outcome. If you tell her at a last minute, oh, now your hyperstimulation, I have to cancel, or I have to convert to IVF and you have to spend so much more, the patient is obviously not going to like it and is going to be a little upset with your clinic. What are the protocols? And of course, don't use the conventional protocol, as Kanti correctly pointed out. You cannot start with a high dose and then step down or step up as we do for normal responder patients. And the protocol of choice here is, of course, the chronic low dose stimulation protocol. So you can see here, you start with a low dose. Normally, we don't go as low as 25, but depending on the patient's BMI and the age, you can start with 37.5, 50, or even maximum 75. Give that for a week or 14 days, then assess the response. Once you have exceeded the FSH threshold, you will see recruitment of the dominant follicles. If you see a recruitment, continue the same dose. If you don't see any response, increase by 50% of the original dose. And you keep doing this every few days till you see the response. And then, of course, you continue till the follicle reaches 18 millimeters, administer your HCG, and then plan the IUI. Of course, there were critics who said that it is the follicular phase is too long, it's too expensive. This was in the past, when we didn't have the flexibility of pens and multi-dose vials. So you had only had ampoules of 75. So there would be a lot of wastage if you were to give 37.5 or 50. But now with the availability of pens and multi-dose vials, you don't have any wastage. So it's very cost effective. And these are all subcute injections, not really painful. So the patient doesn't mind, as long as you don't get hyperstimulation and you don't have too many follicles. A good in-between compromise, if the patient is a little bit on the heavier side and say is about 30, 34, 35, then you could even start with a dose of 112.5 directly instead of starting with 50 or 75. And instead of waiting for 7 to 14 days, you can increase the dose every 2 or 3 days by 37.5 until you see your dominant follicle, and then administer the HCG. And a lot of you would wonder, oh, with this, definitely you will get hyperstimulation, but you don't. You can see 4 out of 10 in these patients still have only a monofollicular growth, excellent clinical pregnancy rate at around 30%, and acceptable, very mild hyperstimulation, just a little bit of ovarian enlargement, no ascites, no pleural effusions or anything else in just about 10% of the patients. So very effective protocol here too. What about the rescue IVF? A lot of them, maybe 20-30%, will have an explosion of the ovaries, whatever you do. And even if you give 75 or 112.5, and suppose you see an excessive response, what do? As I told you earlier, instead of canceling, the best thing is start the antagonist and convert her and refer her to an IVF center. And is this successful? Yes, you can see here in the rescue IVF group, clinical pregnancy rate 45%. In fact, the control IVF group in that IVF center, pregnancy rates were 33% in this study. But the rescue IVF group, last minute conversions of IUI to IVF, extremely successful. Now you would say, why was this higher? Because obviously these patients were not primarily IVF patients. Their only problem is an excessive response. They don't have other complicating factors like endometriosis or tubal factors or hydrosalpinges and so on. And obviously they would therefore have a much better pregnancy rate. But this slide really helps to counsel the patient that, see, even if we convert you, we are not compromising you. In fact, we are taking you up from 20% to almost double, because currently, this was of course way back in 2013, but with current freezing protocols and the freeze-all policy in high responders, we are almost at 60 to 70% with pregnancy rates in this group. So that's how you have to counsel the patient before you start so as not to end up in a soup. Now, of course, to summarize the high responder part, we need to look at the ASRM guidelines. That letrozole is first choice. CC can be used with metformin when you have CC resistance. Multiple pregnancy risk has to be considered. Gonadotropins could be used as second line. Very important point, you can use gonadotropins as first line, especially if you are an IVF center or a specialist who already has experience with follicle monitoring. You could definitely use gonadotropins even as first line and bypass the letrozole and clomiphene sequential protocols if the patient is, say, 35 plus and has already tried too many OI cycles. LOD, of course, I am not too much a fan of LOD, but we know that if done correctly, like Manish said, that if done properly, it could have good results, especially if you're doing laparoscopy for some other reason in the same patient. And when using gonadotropins, as I told you, always counsel for conversion to IVF. And remember to tell the patient about the cost and that you will be doing low dose protocols to optimize monofollicular development, and that still there will be a risk of mild OHSS and multiple pregnancies. What about normal responders? Now, this, of course, all of you know is very easy to do. Protocols of choice here, clomiphene, of course, is first choice. Letrozole is not superior to clomiphene as far as normal non-PCOS patients are concerned. Sequential protocols, clomiphene or letrozole day 2 to 6. Here, of course, you can go high with the HMG doses because you don't really need to worry. And when you're starting on day 6, day 7, the dominant follicle has already been recruited. So you're not really going to end up with hyperstimulation in these patients. FSH or HMG, you can directly start with 75 to 150. You don't need to do the chronic low dose step up if you're using gonadotropins for normal responders. But my personal favorite is, of course, whenever you use gonadotropin, always add the antagonist for best clinical outcomes in terms of pregnancy rates. So this, of course, the normal responders are most of your patients of unexplained infertility. And the guidelines are very clear that CC is superior to expected management. And definitely first line of treatment for unexplained infertility is CC with IUI. Aromatase inhibitors can be used, but there is no difference in pregnancy rates when compared to clomiphene citrate, but could be an alternate if it's your favorite molecule. Sequential protocols, again, will have higher pregnancy rates. Somehow they have said that not recommended because of the higher risk of multiple pregnancies, but I think it's a little overrated, and definitely if you are careful with the use of the sequential protocol, it's worth a try before moving on to IVF. And the same with gonadotropin alone, where they have again said not recommended because of the high multiple pregnancy rate. But again, I feel because our patients are about 10 years younger than the Western patients, it would be worthwhile trying at least a cycle, as long as you are clear with the patient that, okay, if you will respond excessively, I'll convert you to an IVF at the last minute. To prevent all these complications, you need to calculate the correct starting dose whenever you use FSH HMG. And you can see here, best is to use a nomogram such as this, where you have to just plot the antral follicle count versus the weight of the patient, especially useful for PCO patients to know what should be your correct starting dose. For example, you have a patient weighing 65 kg with an AFC of 15. What should be the starting dose of this patient? And it clearly tells you it should be 75. Now, a lot of us might have started 100 or 112.5 or might have started 50, in which case you will not get the optimal ovarian response that you're looking for. And this study shows that in 2018, that in most cases, the FSH starting dose calculated by the nomogram was significantly lower than the one actually prescribed. So most clinicians tend to overdose with FSH or HMG in IUI cycles. So if you want to avoid hyperstimulation, you must apply a nomogram, at least in your initial learning days. What about the poor responder, which is the third and the final category? We know that there are three types of poor responders. One, who starts with a diminished ovarian reserve. So she has a low AMH, low AFC. You don't have any guessing games. You know that she's not going to respond well because she has a reduced number of FSH sensitive follicles. The second category is where she had enough follicles which were sensitive, but you gave her an inadequate dose. So she was not a true poor responder, but she became a suboptimal responder because of underdosing. And the third category is where your dose is enough. She has enough follicles, but somehow the follicles are not sensitive to exogenous gonadotropins. And these are the patients who have polymorphisms of the FSH and LH receptors, and therefore they do not respond optimally. Of course, there's a lot of talk for the poor responder from the IVF point of view, but since we are talking only about IUI today, simple, you can just give her pre-treatment with whatever you believe in, coenzyme Q, resveratrol, Personally, I prefer 20 days of testosterone. You could give your 60 to 90 days of DHEA as pre-treatment. Try to give them some pre-treatment to get synchrony of the follicles. The main important thing in poor responder is that she will just, even if you start with a dose of 150 IU for her IUI cycle, and if you have not given her pre-treatment, one follicle will race ahead and 2 or 3 will be lagging behind. You may be happy that, oh, there are 4 follicles, but finally only one of them will actually grow and become a dominant follicle. Here, you don't have to worry about the starting doses. You can go 150, you can even go 225 because she's not going to have hyperstimulation. You could, of course, add the antagonist to prevent the premature LH surge. You even could, if you are well versed with the use of the agonist, use one cycle of downregulation even in an IUI. Now, I know this sounds controversial. A lot of you saying, what is he talking about? But believe me, agonist with HMG, say 150 or 225, at least one IUI cycle, definitely worth it if she is just a diminished ovarian reserve patient with no other complication, normal tubes, no endometriosis, no PCOS, and so on. So, of course, just to recap this, pre-treatment, sequential, you can directly start because just clomiphene letrozole may not do very well with poor responders. If at all cost is an issue, then you can do the sequential protocol, but otherwise you can directly start with gonadotropins for poor responders when you are doing an IUI cycle. Preferably also add the antagonist. Monitoring, pretty simple. For all patients, day 2 of the cycle, you must make sure that the endometrium is completely shed and that there are no residual cysts from the previous cycle, which you may mistake as follicles. On day 7, you will check the follicles, you will add your HMG. If it's a sequential protocol, you will check the endometrial thickness, make some adjustments of doses and so on. And of course, you're familiar with when to increase and when not to increase. And when the lead follicle is 18 millimeters, you would then proceed with your trigger. For all 3 groups, there are some important common factors. One is, what about dose adjustments on day 7 in gonadotropin cycles? Should you give the antagonist to all? What should be the trigger and what should be the luteal phase support? So what about increasing doses? Now, when you are doing a simple gonadotropin cycle, you start with say 75 or 150, and on day 7, you feel, oh, there are only 2 follicles. I wanted 4 follicles. Let me step up the dose. Does this work? So on day 7 is your scan decision point, and you feel that, okay, the dose is not enough, so let me increase the dose. But you can see here that when you increase the dose, it takes 3 days for the new increased dose to reach a threshold where new recruitment begins. Now, the follicle which has been recruited already has already reached a size of 12-13 mm on day 7, and then you are increasing it to get those 2 more follicles, but those will just be recruited only on day 10. Now, by day 10, this follicle will almost be ready for the trigger. So nothing was achieved by this increase, and this means that you calculated the starting dose wrong, which is why I again said that the most important thing is to correctly calculate the starting dose, because any kind of increase or decrease at a later stage doesn't really work. And the same thing with reduction. In PCO patients, you can't start with 150 and then, oh my God, she's got 20 follicles, let me reduce the dose. Because again, it will take 3 days for new recruitment to stop. So if you had 10 follicles here, and you expect that by reducing the dose, you will stop further recruitment. In fact, you will have 15-20 follicles by day 10 because recruitment will continue for a further 3 days. So this is very important physiology that you have to remember, that even if you stop gonadotropin completely or reduce the dose, the follicle keeps recruiting and growing. What about the antagonist? Now, this is something I feel very strongly about because it is still controversial. A lot of people, some papers say don't add, some papers say add. But finally, you should do it yourself. And remember this slide, which is way back 20 years old, that whenever you use gonadotropins, 1 in 4 patients will have a premature LH surge. Now, when you're making the patient spend so much on the gonadotropin, it is only fair that we avoid this 1 in 4 cancellation, because as it is, you're struggling with a 25% pregnancy rate with IUIs, and you don't want to further reduce this by losing every 4th patient who is on gonadotropin. So it's very simple. You just have to add cetrorelix or ganirelix from day 6 or day 7 when the lead follicle is say around 12 to 14 millimeters. And clearly you can see the minute you add the antagonist, your premature luteinization is completely eliminated and pregnancy rates increase from 15 to straight away 25 to even 30%. And this was another interesting study where they clearly showed that the only difference, the main impact, what really impacted delivery rate in an IUI program was the use of the antagonist, 15% versus 10% when antagonist was not used. Which gonadotropin? Again, nothing much to think here. We have huge Cochrane analysis 2019 comparing rec FSH with urinary, with a HMG and so on, and they clearly found no difference between all these molecules. So you don't really need to worry. It's your personal choice, the cost, and a lot of factors which might take into consideration, that your results will be almost on par with everything that you can use. Only thing is in PCO patients, now that we know that there is an HP-HMG, of course, it's prohibitively expensive for IUI cycles. But if at all the affordability is not an issue, then in PCOs, maybe HP-HMG, because it recruits fewer follicles and gives you the same pregnancy rate, it will definitely reduce your risk of OHSS when you're using gonadotropins in an IUI cycle. Coming to the trigger, of course, we are all familiar with the HCG trigger. And you have to remember that ovulation usually occurs around 40 hours, 38 to 40 hours post the trigger. So simple, how to time the IUI? You have to remember that washed sperms, once you have washed a semen sample, the washed sperm will fertilize eggs only for 2 to 3 hours from the preparation time. So once the sperms are hyperactivated and capacitated, they can fertilize oocytes for just about 3 hours. So if you do an IUI 1 day before the follicles rupture, it has absolutely no meaning, because those sperms are not around when the oocyte is released. On the other hand, oocytes are fertilizable for 12 to 16 hours after ovulation. So the best timing is always to do it post follicular rupture. There is no need to do on day of HCG or 1 day after. Although some of the consensus and some of the guidelines say that, okay, whether you do it on HCG day or 48 hours, it's the same. But I firmly believe this paper from way back in 2015, and I have the same experience that at 42 hours, you have all the highest pregnancy rate as compared to 36 or 48 hours. So probably, especially if you have controlled ovulation with the use of the antagonist, which I do in all my gonadotropin cycles, then you are likely to get your highest pregnancy rate with HCG. Of course, sometimes patients don't ovulate, and especially if you've not given the antagonist, she may end up with an LUF and so on. But remember, 15% of the time, there could be a human error of reconstitution or wrong timing or cold chain not being adequate and so on. What about the agonist trigger? Now in IVF, we keep saying that with the agonist trigger, the luteal phase is deficient. You cannot do a fresh embryo transfer. You have to freeze all the embryos. What about IUI? The same logic should hold true, but we have two interesting papers here, one from 2019, which shows no difference in pregnancy rates, whether you use the agonist trigger or HCG trigger, although to my mind, this is significant, 13 versus 23%, but it did not reach statistical significance as per calculations in this paper. But what really caught my attention was this paper, where you specifically use the agonist trigger when in clomiphene cycles, you find that the follicle is ready, it's 19-20 millimeters, but the endometrium is still just 7 mm. You are tempted to wait for a few more days, but then the follicle becomes an LUF and post-mature. So this is the group where probably the agonist trigger works much better, wherever you have a woman with follicular endometrial asynchrony in clomiphene cycles. And you can see here, when you give the agonist trigger, the pregnancy rates are double, live birth rates are double, and miscarriage rates are much lower than if you would have used an HCG trigger in this category of patients. Luteal phase support, of course, we know that you need to support the luteal phase for all cycles except clomiphene alone cycles. So when you have used clomiphene alone, you don't really need luteal phase support. But whenever you add a gonadotropin or you give gonadotropin cycles, we know that the pregnancy rates will be double with the addition of MVP as compared to no luteal phase support. And we now also have the results of the Lotus trial that even oral dydrogesterone 1 TID is sufficient for luteal phase support in all cycles, whether it is fresh embryo transfer or it is an IUI cycle, wherever you have a functioning corpus luteum. And of course, remember that don't go on and on and on with IUI. The patient will really appreciate you much more if after a couple of IUIs, you tell her, okay, I think you need to go for an IVF. And she will definitely come back to you very grateful that she was referred for IVF at the right time. So to summarize, poor responders, as I told you, pre-treatment starting doses could be as high as 150 to 25. Try to always add the agonist antagonist for a better outcome. Start normal responders, use a nomogram if you're not sure, and between 75 to 150, can add the antagonist, but don't use agonist because you don't want hyperstimulation for the down regulation. And high responders, of course, only chronic low dose step up. Starting dose as per the BMI, counsel always for cycle cancellation or for rescue IVF, which I think is very successful, and also counsel them that you might have mild discomfort and a slightly higher risk of high order multiple pregnancies. So just before we conclude, a few just simple tips that gradient method, of course, is better than the swim up. The total progressive motile sperm count, I told you, should be more than 500,000 in male factor infertility to give you the best pregnancy rates. TSP, that is the time from sperm preparation to the actual insemination, should not be longer than 80 minutes. Ideally should be 60 minutes, but should not be too short either. You can see here, if you wait for 2 hours after a processing of the semen sample, your pregnancy rates are not the best. For male factor, the best thing to do is take 2 semen samples. So you ask for one at 8 a.m., ask for a second sample at 9 a.m., pool them together, and very often you will see that the second sample will have better sperm counts, better motility, and better vitality. And if you use consecutive ejaculates, your pregnancy rates will be the same as your non-male male factor IUI patients. No need for any bed rest. In fact, you can see in the gonadotropin group, immediate mobilization pregnancy rates were 30% with 15 minutes bed rest 11%. Of course, it is not statistically significant, but definitely there is no decline in pregnancy rates if you immediately ambulate the patient and make a move around. And finally, you must be truthful about success rates, and a good slide to follow. Clomiphene citrate alone 7 to 8%, HMG 16%. Again here, sequential 16%, and gonadotropin alone around 23%. Today, with better improved laboratory techniques, I use this slide to counsel my patients that, okay, you can expect these kind of success rates, but the best is, of course, gonadotropin with the antagonist, where you consistently get around 30%. So to conclude, unstimulated IUI, very low pregnancy rates, so stimulation is mandatory. FSH and HMG are better than clomiphene and letrozole for normal and poor responders. Letrozole HMG better than clomiphene HMG for poor PCOS and high responders. Sequential protocols, of course, are cost effective. Giving very high doses of FSH does not improve pregnancy rates, only increases the complications. Agonists probably have no role to play in an IUI program, but I told you in very poor responders, you could try one cycle if at all you have to. Antagonist gives a significant improvement in pregnancy rates by eliminating the 25% premature LH surge. Trigger, of course, is essential. Luteal phase support is required. Timing at 42 hours and incubator to womb time is critical. Mild stimulation protocols still in the process of a lot of clinical studies and all going on. 3 to 4 cycles maximum of IUI are enough before resorting to IVF or ICSI. Remember that ICSI and IVF today have a 60 or sometimes 70% pregnancy rates with good FETs and freeze-all cycles. So definitely a very good option. And for male factor, of course, ICSI is better than IUI. So as we look to the future, there are a lot of shifts in the approaches and the guidelines. We also know that pregnancy rates with IVF have constantly been increasing every year by 3 to 4%. No similar increase has been seen with IUI. And we have to, maybe 5 years down the line, we may not be talking about IUIs anymore, the way IVF pregnancy rates are increasing. So of course, these are controversial areas, but it seems to be heading in that direction. So once again, a big thank you to Kanti, all the organizers, all my co-speakers, the wonderful panelists to come, and to Baroda OBGYN Society for this great opportunity. Thank you so much.
Thank you very much. Yes, Jatin, thank you. As usual, very scientific.
Thank you.
Yeah, it's a very practical points you have narrated, which is very good for the best result of the IUI. For the best IUI result, we need selection of the patient, best stimulation, triggering, best preparation of the semen, insemination, and best luteal support. All things you have narrated very nicely.
Thank you.
In precise time. It was very practical lecture, which is useful for the all routine gynecologist. So thanks a lot for this scientific lecture. As usual, you are the Amitabh Bachchan of the IVF. You are my good friend. So over to participants for any question about the intractable ovarian management to Kanti Bansal and to Jatin also. Yes, Manish.
Yeah,
Yes, Manish.
Dr. Patel, I would like to ask one question. Dr. Jatin,
yeah,
can you be more specific for pre-hormonal treatment for follicular synchronization?
Yeah, so that's my favorite topic. But it's very important in IVF because in IVF, you're dealing with 50% of patients are poor responders. So synchrony is really very important. A lot of the problems with the antagonist protocol which we face in IVF are because you don't get enough top quality oocytes and embryos because of follicular asynchrony. because we have a tendency to start on day 2. Sometimes we even start on day 3. Some people even start on day 4, thinking, oh, it doesn't really matter. But remember, there are endogenous FSH surges even in the late luteal phase of the previous cycle. So the recruitment of the dominant follicle has already started. So if you start gonadotropin on day 2, your dominance has already happened. And that is why, one follicle races ahead to 18, the others are lagging behind at 14, and you don't get a synchronous cohort. So that is why still 50% of my patients, I prefer the long agonist protocol, because that was the beauty of the down regulation protocol, that you completely cut off endogenous FSH LH before you start stimulation. You get a beautifully uniform cohort of follicles. Now in the antagonist, you can achieve the same by 2 or 3 different ways. One is the use of estradiol valerate. So you give estradiol valerate 2 milligrams twice a day from day 25. Okay, so this will suppress the endogenous FSH surge. She comes in on day 2, day 3, you do the ultrasound and start your gonadotropin and stop the estradiol. The second easy way is to give norepinephrine. You can give it BD from day 20, minimum 7 days, maximum 14 days. Stop anytime in between and start stimulation after 5 days. Don't use OC pills, especially if it's a PCOS undergoing an IVF cycle, because a PCOS will need an agonist trigger. Now, when you give prolonged OC pill pre-treatment, you will completely suppress her endogenous LH. And the agonist trigger is based on the principle of releasing endogenous FSH and LH as the surge, as compared to HCG, which mimics only the LH surge, right? And that is why you should not be giving OC pill pre-treatment to egg donors and high responders before IVF. Otherwise, you will not get a good response to the agonist trigger and keep thinking that agonist is not as good as HCG. So we get a mental perception that they are different, and we keep trying to give HCG and then end up with hyperstimulation. The best for IVF is just to give the antagonist on day 2, 3, 4. So this is now what we are following for all non-PCOS patients. That means all normal responders and poor responders. We give antagonist on day 2, 3, 4. And from day 5, we begin the stimulation. So this is the best way of doing it. So these are some of the key points. I mean, IUI, maybe antagonist and all may not be cost effective. So you can stick to the estradiol valerate or norethisterone. So, and if you really love the oral contraceptive pill, you can give it just for 10 days, not more than that.
10 days, not more than that. Yes, very true. What we can do is we can give Proginova from the 21 day for 5 days along with antagonist on alternate day 1. And you can start on day 3 of the stimulation. Yes, rightly said, Dr. Jatin. Yes, you can give.
Dr. Jatin, what I have seen is that by giving progesterone, that gives a better result in cases for asynchrony rather than estrogen. That is my personal opinion.
In PCO or normal response?
PCOS.
No. So I said only for normal I was talking about. Because in PCO they are anovulatory, so you can't use norethisterone.
And also what Dr. R.J. Patel said, I think we can use antagonists before starting that also helps in some few cases.
Yeah. So actually the first paper by Fanchi in 2016 or something was 3 milligrams of antagonist on day 25. That single dose, very high
dose. Long acting single dose.
It got modified. Finally,
now with estradiol valerate for 5 days, you can give antagonist, maybe single dose, maybe alternate day for 3 or 4 doses. Then wait for the period. You can start from the day 2 or day 3. Then your synchronization will be better.
Yes.
Jatin bhai, one question. Hello.
Yeah.
Yes.
Jatin bhai, what is your experience regarding the letrozole and clomiphene combination? 5 milligram plus 50 milligram.
Yeah, so far I think we've done about 20 patients, but most of them have been added up with sequential protocol. But I find that the initial recruitment of follicle is a bit better than if you use either one alone. Sometimes in letrozole on day 7, you don't see a recruited follicle. Sometimes in clomiphene, you don't see. When you give a combination, you at least have 2 or 3 follicles recruited by day 7 or day 8 of the cycle.
So your selection protocol based on previous response of letrozole and clomiphene. Yeah. Then you combine both.
Yeah. And add HMG also.
Okay.
Yeah. They can take letrozole clomiphene together at bedtime?
Yeah. Both together.
Letrozole CC together at bedtime.
Yes.
But in previously, you had seen response of both the drugs individually.
Either one, or she has come with some previous notes or previous treatments, all that kind of.
So 25%. And what is the result, sir?
Pregnancy rate is same, around 12 to 15% max.
But recruitment of follicle is
Manish,
yes,
easier. It may not translate into, but day 6, day 7, if you don't see a follicle, then you have to again start HMG and then get hyperstimulation and all that. So that part is avoided.
Okay, yes, RG.
And increasing the dose of letrozole, like escalation either at the beginning or every day.
Yeah.
What is your experience, gentlemen?
Yeah, so we have sometimes given 5 milligrams for 10 days also, if it's a very resistant case. So all that we have tried, but normally I like to add HMG. So I don't go on and on because most of the patients who come to our clinic have already done all those things. So we have just, we give letrozole, maybe maximum continue it for 10 days. But day 7, day 8, I will definitely start gonadotropin also for that patient.
Yeah, same. What we are doing in a poor responder, in a case of dual stimulation, twice stimulation in the same cycle, we are giving clomiphene citrate 25 milligram along with the letrozole with the small dose of HMG.
Yeah.
When the follicle become mature, we can trigger with the analog, GnRH analog, and we'll do pickup. Again, in the same cycle, after 5 days, we can do restart the HMG and we can do. So this is the Shanghai protocol. What we have learned, the CC and letros together we can give.
Yeah.
So same way, Dr. Jatin rightly say, we can apply in IUI also.
Yeah.
Right. Okay, sir. Looking at the time constraint, I think we can move to the another session. I extend my sincere thanks to all the chairpersons and for the fantastic presentation to both the speakers who have given us the greatest information and the knowledge in present era. Thank you very much.
Thank
sir.
you.
Thank you.
Thank you, madam.
Thanks.
Thank you.
I will invite now Dr. Ashish sir for his next quiz questions. Dr. Ashish sir.
Till Ashish is sharing the screen, there are a few questions in the chat box if one can answer there.
Shall we finish the questions from the chat box? Then I'll begin. Dr. Ashna.
Hello. Dr. Jatin, you got question that how to prevent premature LH surge in CC cycle.
Yeah, I'm answering in the chat. Since you are short of time, you please go ahead with the session. I'm answering them.
Thank you, sir.
Okay.
Thank you so much.
Running short of time, so you can proceed.
Thank you, Jatin bhai. So nice of you.
So shall I proceed with the permission of the chairpersons?
Yes.
Yes.
Okay, so I'm back again. And as I said, the race is not over. It is the last leap that leads to a win. So let's see with the next set of questions, and the rules remain same. You're supposed to answer on WhatsApp as you have already done. So you all are aware how to do that. So here is a 6th question. The specific clinical diagnostic criteria to define polycystic ovarian syndrome are called as. Again, we'll give you 1 minute to answer. Dr. Deepa, please keep a track of the time.
Yeah.
So diagnostic criteria to define polycystic ovarian syndrome.
Next question, please.
So here comes the 7th question. Out of the few effective yoga asana for the treatment of PCOS, one is demonstrated here. What is the name of this asana? You can answer either in Gujarati or English or Hindi. Any language is fine to answer this question. I'm sure those who are into yoga would know this answer. So Dr. Deepa, can you please tell me when 1 minute is over?
Yeah. Yes, next question, please.
So we're moving to the 8th question. This person has significant revolutionary contribution in the treatment of PCOS. Who is he? So again, a question based on a personality. His contribution is in the treatment of PCOS. Who is he? Getting already many answers here on my WhatsApp. And 2 more to go after this.
Next question, please.
So the second last question.
Next question, please.
The 9th question is on your screen. In context to womanhood, how is the PCOS frequently described? In context to womanhood, how is the PCOS frequently described? The picture here is just representative of what happens to womanhood with PCOS, and that's how I've kept this picture. Just 1 more to go after this, so try your best. And may the best be the winner.
Next question, please.
Okay, here comes the last question. In her Instagram series titled as Story Time with Dash, she gives a few tips and hacks on how to deal with PCOS based on her own experience. Who this Indian celeb is? I have taken this snapshot from her Instagram storyline. So in her Instagram series titled as Story Time with Dash, she gives a few tips and hacks on how to deal with PCOS based on her own experience. Who this Indian celeb is? Maybe you can just look at the picture and answer if you don't read this sentence. I don't know.
Yeah, that brings us to an end of this interesting quiz session.
Thank you so much. Thank you.
Thank you very much, Dr. Ashish, for this quiz. Now we are concluding our first session and moving to the second session of the panel discussion. I would invite Dr. Doley to conduct the panel discussion, the session of the panel discussion. Dr. Doley, please.
Thank you, ma'am. So after the crisp take-home messages from the 2 eminent speakers, we have a panel discussion on the 2 important topics, that is PCOS and endometrioma. So may I invite the moderators for the same. The first moderator for today's panel discussion is Dr. Archana Dwivedi. She is a senior and a renowned gynecologist from the city of Vadodara. She is the head of the department. She is the head of gynec department at Sterling Hospital. She is multi-talented, past president of Vadodara Menopausal Society and the current president of BOGS. Welcome, ma'am.
Kind of here only, that's fine.
So the second moderator for today needs no introduction. She has been a mentor to many gynecologists. She is a very senior gynecologist from the city, from our own very city. She is a clinical head at Oasis Fertility. May I invite Dr. Shushma, ma'am, please?
Thank you. Thank you, Dolly.
Welcome, ma'am. Over to you, ma'am.
Thank you very much. After that most mesmerizing session of Dr. Jatin and a very lovely ovarian lecture of Dr. Kanti Bansal, we are going through now the office practice of 3 cases of interesting cases, difficult also to see that how it works. So I'm happy to have my moderation shared with Dr. Archana, a very dynamic lady of Baroda Obstetrics Gynec Society and the president. I hand over her to start with the panel discussion.
Thank you, ma'am, for the kind words. Indeed, we had a very good eminent speakers with a very practical take-home messages. And here with madam, we have tried to take the practical cases which come in the OPD with a twist everywhere. So I invite all our esteemed panelists along with my moderator, Dr. Bakshi madam, Dr. Ajay Walia sir, who's practicing infertility specialist in Vadodara. Dr. Manoj Pandya is from Ahmedabad. Munjal is currently the president of Ahmedabad Society, and Dr. Secretary of Ahmedabad Society, and Juhi Agarwal from Bhopal. Dr. Vaibhav Kapadia from Navsari. I cannot see Vaibhav, are you there, please? Dr. Yuvraj Jadeja from Vadodara now. So we have got this good learned team of panelists, and we'll start the discussion with the very practical cases which come day to day in our OPD scenario. So over to you, Sushma madam, to start with the first case.
Thank you, Archana. With thanks to BOGS and Dr. Kanti Bansal, we start with our first case with a saying of Dr. William Osler. He says that he who studies medicine without books sails an uncharted sea, but he who studies medicine without patients does not go to sea at all. And that is why today we are going to discuss the cases which have really, these are real cases which me and Archana have faced, and we would like from the expert gallery of panelists to have answers.
This minute में डाल दिया तो startup में तो apps ले रहा है.
Mute yourself. Yes, ma'am.
So case 1, Mrs. KZ, 34 years, having primary infertility of 6 years, is having history of irregular periods for last 10 years. No androgenic features. Her menstrual history is initially only withdrawal bleeding of 3 to 4 days every 6 months with moderate flow. Her last menstrual period is 3 months back. In past, she has taken treatment for ovulation induction and intrauterine insemination 3 times. She is otherwise stable on antihypertensive, which she has been taking for last 3 to 4 years. Her BMI on examination is 34.3. Her weight 104 kg. Blood pressure as on now is 120/80. She is on antihypertensive. There is no hirsutism or acne. Acanthosis, breast is normal. On physical examination, everything, rest of things are normal. Her pelvic examination is normal. On transvaginal sonography, her uterus is normal. With 3 months amenorrhea, her endometrium is 7.4 mm and thick. Bilateral ovaries are bulky with antral follicle count on right side 15 and left side 20. The volume of ovary is more than 12 centimeter cube. So the clinical diagnosis of this case is obvious. She is a case of PCOS with primary infertility and morbid obesity. The lab tests which were done on her are her FSH is 4.1, LH 7.8, which is higher. Her AMH is 10.6. Her HbA1c is 5.9. Her thyroid and prolactin are normal. Lipid profile is disturbed. HOMA2 index is more than 1.6. LFT is normal. Her HSgraphy, which was done some 3 years back, the tubes were patent and Simon parameters were normal. So the first question is to Dr. Juhi Agarwal. In this case, what are our concerns?
Ma'am, first of all, a very good evening. I think it's all good evening now. Good evening to every one of you, and thanks for giving me this opportunity on this forum. So here, as Dr. Kanti has well said, that this comes in categorization of PCOD type 2. And the concerns are, of course, her age. She is already 34 years of age. She has a metabolic syndrome as per her investigations, and her AMH is high. So all over, her concerns are not only the medical part, but also related to infertility. So we have to take care of both of these things. So these are the major concerns: age and her all the values suggesting metabolic syndromes along with infertility.
Dr. Vaibhav, in this case, she is already on folic acid D3, but would you like to start with metformin in this case?
Sure. Actually, we would like to start her on metformin, especially when her HOMA index is higher or her fasting insulin levels, sugars to fasting insulin levels are also higher. We would like to start her on metformin. Ideally, start her with 500 milligrams as a sustained release for first few days, increase it then to maybe 1 gram in divided doses, and then probably repeat a fasting sugar to insulin level ratio and then titrate the doses accordingly.
If she is having gastrointestinal upset with metformin, what would be your choice?
No, ideally, that's why most people will have a gastrointestinal upset. So we would try and counsel them and start on a minimum possible dose, and then start slowly increasing the dose to a titration as to where she's well controlled, especially with her glucose insulin levels, along with, of course, lifestyle modification and her dietary restrictions and everything that goes beyond.
And I suppose you would like to continue metformin all throughout?
Yes. Yes, so if she does, fortunately with our treatment, with whatever treatment she further undergoes, if she gets pregnant, we can definitely safely continue this all the way up to even 34 weeks of pregnancy.
That's great, Vaibhav. My dear friend, Dr. Ajay Walia, I would like to ask you, because Dr. Kanti says that she's very happy with myoinositol, and what is your take on other adjuvants which you would suggest in such case? And what is the role of myoinositol in your eye?
Yeah, along with lifestyle modification, metformin, stress on weight reduction, and I definitely give a combination of myoinositol and D-chiro, both. It is a type of an insulin sensitizer, and it does help. And especially the quality of ova or eggs improve, chances of pregnancy also improves.
In what dose you would like to give myoinositol?
Ideal is 2 grams of myoinositol and 40:1 ratio D-chiro combination.
And would you like to give myoinositol for 3 months and then start with the fertility treatment, or you would like to start it simultaneously?
See, most of the time when the patient comes, they don't like to wait. And even if you tell them that you reduce your weight and you come back, they are not happy with it. So you have to give everything together. You can't just wait. That is a practical solution.
That's a practical solution. So you would like to start with, though the Cochrane review says that it is of low evidence to give myoinositol, but the thing is that there are not many RCTs to substantiate the use of myoinositol in PCOS. However, the papers which are there, which it does show definite improvement in oocyte quality and the fertilization rate. Dr. Manoj, you must have seen in the history that her BMI is 34.
Correct.
So would you like to ask her to use her weight first? 104 kg, I am scared.
Yeah, apart from BMI, from the history, I will like to stress upon that her age is 34, and yes, she is normoandrogenic, so she falls into the category of phenotype D.
Yes.
No doubt. So when the question is being asked whether obesity management first or fertility treatment first, considering her age, I will definitely go for fertility treatment first, along with the advice for the weight reduction, because as we all know that obesity definitely affects or make the severity of the phenotype more worse it delays the conception as far as the age is concerned, and we need higher dose of the various medicines for ovulation induction. No doubt, with obesity and PCOS, the risk of treatment per se it is not increased, but it is the risk of complication, pregnancy complication, which are increased when PCOD and obesity are associated. So, in such late reproductive years of her life, when we are planning to postpone the pregnancy to get the benefit from the weight reduction, we should balance it against the decreasing fertility with the advancing age. And if she is competently well-informed, educated, we should leave this decision to her, advising her that if you go for the fertility treatment first, it will benefit you a lot. And obesity is a changeable condition, but age, like diabetes, when age is increasing and biological clock is tickling, we cannot change the age. So I will definitely go for the fertility treatment first, and then with the weight reduction.
That's very right, Dr. Manoj. Dr. Juhi, the patient did ask me that my AMH is 10 and my weight is 34. So why you are worried about the oocytes? Because I'm going to have lots of oocytes in my ovary. So why you are worried? Let me wait. Dr. Juhi, please.
Yes, ma'am. Ma'am, the patient is telling that I should wait. But as we know that the quality of oocyte, they decline as the age advances. So as very well said by Dr. Manoj, that we have to do it simultaneously, the weight reduction as well as the pregnancy treatment. They should go hand in hand. And we have to counsel the patient. Here comes the role of counseling of a treating doctor. Counseling plays a very important part. We have to clear all the queries and explain the beneficiary that this will go wrong if we'll wait, and this will not go wrong if we don't wait. So it is like that. Counseling plays a very important role in such cases.
Truly so, Dr. Juhi. And as Dr. Walia said, that the lifestyle change and some of the anti-obesity drugs and exercise and diet, everything we would advise, which would go hand in hand with the fertility treatment. We all are aware that obesity is frequently associated with higher circulating levels of insulin, increased ovarian androgen production, and it gives negative feedback, the high estrogen on the HPO axis, leading to ovulatory dysfunction and menstrual abnormalities. Thanks or no thanks to COVID era, because she came to us last year, and then during that time there was lockdown, and by that time we had advised her that you will have to reduce your weight, and she was determined. I must say hats off to her. She went to a bariatric consultant. We had advised to meet, and she lost 11 kg in 5 months. During those 5 months, with this, her menstrual cycles improved, but still, majority of them were anovulatory. So this is what happened in those 5 months. Now she's asking that now, since I have reduced my weight to this extent, Dr. Munjal, can you say that ovulation induction, how you would prefer to do?
Yes, thank you, ma'am. Actually, with regards to weight reduction and metformin, which will actually go hand in hand before doing anything related to ovulation induction, we would like to go for letrozole most because letrozole is something which is having better results when it comes to ovulation or rate of ovulation. Multifollicular development is again less as compared to clomiphene citrate, and as per research data, congenital anomaly, if the patient conceives, is little less as compared to clomiphene citrate. So the dose, or the starting dose would be around 2.5 milligram per day of letrozole from second or third day of menstrual cycle, with after doing the baseline scan of both the ovaries and endometrium, or thickness of endometrium, we would start with letrozole. That would be the first choice.
So you would definitely offer her IUI and ovarian stimulation.
Yeah, according to her age, as previously said by Manoj sir and Juhi madam, that 34 years, we would definitely go for IUI. And as again, many of the data would suggest that ovulation induction followed by IUI would be, giving a better results as compared to timed intercourse after ovulation induction.
Surely so. I think that's a very right message which you have given. And to Dr. Yuvraj, I would like to ask, Dr. Jatin has just now said that I would like to add gonadotrophins. So sequential treatment I would like to do. What is your opinion on that?
Yes, ma'am. Thank you for the question. I agree, ma'am. I think that would depend on what, I think she's had 2 to 3 previous cycles of IUI. So if she's had oral ovulation stimulation previously, and if we still want to try an IUI, it makes sense that we add gonadotropin. Of course, with an AMH of 10, it's going to be a little tricky. But at the same time, if you do a sequential letrozole plus a gonadotropin, you could save that danger of multifollicular development and cancellation of a cycle. But I would still want to try having some experience with a chronic low dose protocol with 37.5 in these cases, and sometimes that do work. So the question of trying an IUI with gonadotropin definitely still remains in this patient.
And how many cycles you would do?
Ideally, ma'am, I personally, I mean, if you talk about the consensus, it's either 3 or 6 according.
Yuvraj, we want your opinion.
All right, ma'am. So if she has already done 2 cycles before, and if they were not with gonadotropins, I would still ideally do 1 or 2 cycles with CC plus letrozole plus gonadotropins. But if she's already done a gonadotropin cycle before and not succeeded, then probably 1 more cycle and then counsel her for IVF.
So definitely not more than total 3, maximum 4 cycles. And this patient also underwent 2 cycles of controlled ovarian hyperstimulation with IUI, and unfortunately she did not conceive. So at this point of time, Dr. Vaibhav, your choice of laparoscopic ovarian drilling is there or it's not there?
Actually, in a patient who's already 34, I would initially, if she gets counseled for an IVF cycle with a failed IUI, I would just go ahead with an IVF cycle. But sometimes, in all practical purposes, they cannot afford IVF. They just cannot afford even probably gonadotropin treatment. Then laparoscopic ovarian drilling could be an option in these cases who are CC resistant, and probably go ahead with that. But that would not be my first line of treatment for this patient.
Any day you would prefer IVF over LOD in this case?
Yes, absolutely.
Dr. Juhi, do you have?
Yeah, I totally agree, Dr. Vaibhav. Since I am in an institute where we don't have facility for IVF, it's a costly affair. And of course, the patient, the class of patient we are receiving, they cannot afford. Yes, we do ovarian drilling because we don't have an option. So in that case, you can always go for ovarian drilling. And but IVF would be the first choice, of course.
Dr. Manoj, my patient is asking that does PCOS and obesity, which I have, she's a Google patient, you know, that does it affect the oocyte quality, implantation and pregnancy outcome?
Definitely, yes. It affects at all 3 levels, because obesity associated with PCOS, it impairs the oocyte maturation and metabolism. In obesity, superadded with PCOS, there is hyperinsulinemia, insulin resistance, glucose homeostasis is disturbed, free fatty acid level, adipokine changes, all these things in the oocyte, they negatively impact the developmental competence of oocyte, and ultimately it will result with the poor pregnancy outcome. Even there is a change in pre-ovulatory follicular fluid environment when patient has got obesity as well as PCOS. So oocyte quality is definitely going to be affected. But if by chance, if she conceives, she has to get the fertilized ovum has to get implanted into the uterine cavity. Now, when it comes to successful implantation, that it is a receptive endometrium, then the blastocyst at a proper stage, and a synchronized dialogue between the maternal and embryonic tissue, it is must to have a successful implantation. But this endometrial receptivity in PCOD and obesity, because of the hyperinsulinemia, because of the insulin resistance, because of the hyperandrogenism, It is, and as such, receptivity is metabolically very demanding. And with all these conditions, when this metabolism is altered, the implantation will not be that much successful. And as far as pregnancy outcome is concerned, we should focus on 3 areas: maternal outcome, fetal outcome, and as well as long-term outcome as far as mother is concerned. Maternal outcome, naturally, with PCOD and obesity, she has got high chances for preeclampsia, gestational diabetes. Even maybe because of the gestational diabetes, she may have large for macrosomia. As far as fetal outcome is concerned, there are chances for preterm delivery, small for gestational age, and high rate of neonatal admission after the delivery. When we are thinking of long-term outcome, she is at a higher risk of developing cardiometabolic complications if she has got PCOD, obesity together. So we should convince, or we should counsel properly that both these risk factors are definitely going to affect all the 3 factors: oocyte quality, implantation, as well as pregnancy outcome.
That's an excellent piece of counseling, Dr. Manoj, which you have offered. And before going for IVF also, all these points should be considered for her. If we go for IVF, which we have decided now, which gonadotrophin I should be using, Dr. Vaibhav?
Actually, as Dr. Jatin also said, that either product, urinary or recombinant, gives us adequate results. The only reason we choose a recombinant FSH is because you can titrate the dose slightly easily. You can even give us slightly smaller amounts of doses because of the pen, which is easily available. So the wastage is less. You can titrate it more easily. Also, along with PCOS, we follow an antagonist protocol, and we use a freeze-all protocol as far as possible, because what you're worried about ideally is ovarian hyperstimulation in these cases. And when you use an antagonist protocol with a lupron or a GnRH agonist trigger, you can be able to freeze all, and this reduces this risk dramatically. And with the freeze-all protocol, with the transfer in the next cycle, you're able to get extremely good results.
That makes you very safe, IVF specialist, Dr. Vaibhav. Dr. Ajay, you have any specific gonadotrophin of your choice to be used in this case for IVF?
Looking at the age and looking at the AMH of 10, I would prefer a recombinant FSH for this. Again, a step-up protocol and all freeze with antagonist trigger. All freeze.
I mean, that is one of the most important point. And we have already started with metformin, so chances of OHSS is definitely low. So this patient, what we did was we started with recombinant FSH 225 units and of course antagonist protocol. Her OPU was done after 9 days of stimulation. That time her E2 was 5000 odd, P4 was 0.6. We gave agonist trigger, 24 oocytes, out of them 18 were M2, 11 blastocysts have been frozen, were grade 1. We wanted to transfer in April, frozen embryo transfer. In that time she was COVID positive, so her ET was not done. So, Dr. Yuvraj, when can we transfer embryo? Now, I don't know, please. In April 2021.
Hello.
Dr. Yuvraj.
Yeah, ma'am. So honestly speaking, ma'am, if she's got COVID and we are wanting an embryo transfer now, the embryos are frozen, I would personally at least advise her to get vaccinated first with 2 doses and then probably encourage her to do an embryo transfer. But in case if that's not what we want, I would wait 28 days post she becomes symptomless before I think of a transfer. So 4 weeks.
Dr. Juhi, I would like to have your opinion. You are much concerned about this COVID things as on now.
Yeah, yes, ma'am. Actually, I've gone through certain guidelines ICMR has issued, so we have to keep, we have to take into concern those also. We should definitely counsel the patient regarding the COVID, and further, she is an obese patient and she has all risks of developing hypertension, diabetes in near future. And if at all, despite of vaccination, if she succumbs COVID, we should always warn her regarding the pregnancy status during this COVID pandemic, because you still don't know where this COVID pandemic is going to end. So you have to always counsel the patient, and with all those consent and counseling, you keep that medical record with you and then go for embryo transfer if the patient agrees to it and all the things. So informed consent and counseling is very important in these patients. And of course, vaccination, as Dr. Yuvraj has already quoted, that you have to ask the patient to get vaccinated first and then counsel regarding all these things and then go for embryo transfer, because embryos can be preserved for long. And this pandemic, you don't know when it has to, and I have seen many complications in pregnancy, and that too in patients who are hypertensive, pre-eclamptic, and COVID having all those thrombotic events coming along with that. And also fetal complications. Lot of oligohydramnios and IUFDs and preterm death. So that is why it is very
Madam,
important.
may I interrupt? Sorry, if possible.
Yes, please, please.
So actually, the ideal thing to do in this case is wait for 14 days once her acute illness is over. Once the acute illness is over, she's completely recovered from COVID. You can check her for antibodies. Once the antibodies are positive, there's usually very unlikely that she's going to get COVID again in the next 3 to 6 months, because that offers her innate immunity. Obviously, immediately post-COVID, 2 months, you're not recommended to take any vaccination. So if you're going to wait for 2 months for her to take a first dose, another 6 to 12 weeks to take a second dose, that would mean that you're entailing or trying to tell her that she cannot come for a transfer for the next 4 to 6 months. Ideally, a lot of people who are coming to the IVF clinics are not willing to wait for that long. So if she's completely medically safe to carry on with pregnancy, anytime after 21 days since her detection of COVID, and she's developed a good amount of antibodies, you can go ahead and safely give her an embryo transfer in the next cycle.
Fine, we will. Yes, Juhi, I know there will be lots
yes,
of.
Yes, sir. Yeah. No, I would like to add one thing, that definitely informed consent and a medical certificate is required from the treating doctor. That yes, this patient is now fine, she is off COVID, now no problem, you can go for embryo transfer. You have to keep, for medical legal purposes, you have to keep that medical record and then proceed. And of course, all the consent, the written consent should be there. That yes, I agree to all the terms and condition. I know everything about the complications of COVID, being COVID positive in near future, and everything about that.
Absolutely, absolutely. I mean, I request all the people who are listening to this to refer to ASHRAE guidelines for COVID treatment and infertility treatment. So,
Sushmit, can I ask a question?
Please.
You had started 225. You didn't use a step-up protocol. How did you come to 225?
We had that's what I mean, based on my experience, that I started with 225 recombinant FSH.
Because she's already obese also, 100 kg plus.
I mean, she had reduced her weight. So when we started with her treatment, she was 90 kg.
With 10 AMH?
10.
Okay. That's okay.
So I think Weber has made a point over here. Madam's in his hand. Lakshmi ma'am, are you still with us? Or else I can share the screens. So till Madam is rejoining, I think Weber, you made a point very clear that IVF patients don't have so much time to wait, and with the latest guidelines, you're right that then within 28 days of this thing, we can always do the 8 days of this thing, we can always do the ET.
Absolutely.
Yogendraji, can I start sharing? Because I think Madam's network is not there. Just give me 1 minute.
Yes, ma'am.
I'll just start sharing the screen as Madam is.
Yeah.
Give me 1 minute. Bear with me 1 minute. I'll just open the slides.
Actually, madam, the difference is that I am on the other side of the spectrum. I am in a government setup and I see many pregnant women dying.
Julia, I would agree with you that informed consent is very, very important. And government setup, we have got less resources, but we have to go and the practical guidelines are generated from there only. So whatever you have said is completely fine. But I just wanted to say that we always don't have that luxury that patient is going to
very true, very true.
To understand that also. So that was the whole thing. And see, if you have to wait for 28 days, and then again you say that is my screen visible?
No, madam. Yes, now it is visible.
It is visible.
Now it's visible, ma'am.
Yeah, case 2.
I just go on the show mode and I will start up with the case 2. Just a second.
I'm sorry, I was dropped from.
No problem, ma'am. I think when I put it on show mode, I stopped seeing lovely faces, so I'll go this way only. So here I'll present you the second case, a very, very common adolescent girls who walk in our OPD. Mrs. RJ is 19 years, she is unmarried and has got a history of dysmenorrhea, irregular heavy periods. There is no bowel or bladder disturbances with her. She started her periods at a normal menarche age, 14 years. And she has so much of pain that she has to go for injections also. So now how do we proceed in this case? Am I seen? I'm just having some problem with the sharing. I'm sorry.
Madam, if you can start the slideshow.
There is no problem. Bakshi ma'am, can you share? I had some problem.
I'm trying from another computer.
Okay. So let me. Let me try it for once more. So this is a case of endometrioma with what we are talking about. I think it is seen now. But... Okay, I'll just go quickly. I think it's done, madam. Don't bother. I am able to do that.
I'm really sorry.
It's okay. I'll do that. No problem. So this is a girl which routinely comes in our case and she has to take injections for her pain. When I examined her, she was conscious, cooperative. Her BMI is 24, vitals stand to be normal, and secondary sexual characters are well placed. Transabdominal sonography shows that there is a normal uterus and bilateral homogeneous cystic 5 into 5 centimeters, as you can see here, and 3 to 4 centimeter without internal vascularity. Solid areas and septations are seen on both ovaries and pouch of ovaries. No fluid is seen, however, in pouch of ovaries. So ASRM states that endometriosis should be viewed as a long-term chronic disease which needs a lifelong management. And we have to plan with the goal of maximizing the use of medical treatment, avoiding repeated surgical procedures. With this statement, I would like to ask all the panelists that now the diagnosis is bilateral endometriosis. Lab tests are normal, AMH is 6.5. So how should we proceed now? We can start one by one. We can start with Dr. Ajay Walia, sir.
Hello, can you hear me?
Yeah, we can hear you. The whole idea is that this case you want to go conservative, or what is the next? Anybody differs, sir?
I will straight away operate because she has been suffering from a severe dysmenorrhea, intractable. She had to take an injection, and she's 14 years. If we don't operate now, this disease is going to progress. Medical management is out. Just for temporary, if she's not fit as on now, or she wants to pass some time, 2 months, exams or whatever it is, Ideal is the operative laparoscopy.
Okay, sir. So, Munjal, what are the clinical laboratory?
Dr. Arjuna, can I intervene for this?
Yes, Manoj sir. Yes, yes. Everybody's opinion is very important. Yes.
See, definitely, whenever a decision to make a whether surgery or conservative comes, it should be a symptom. We should focus on the symptoms. We should give the preference to the patient and what are her priorities. But in this case, the early ablative surgery will definitely help her because it will have a low morbidity. It will relieve her symptoms very fast or very early. She will definitely have a better quality of life. It will be less invasive at this stage because still disease has not progressed to a certain extent, and it will be less damaging to ovary also. So definitely surgery will help her.
Okay. Any difference, Dr. Juhi? Would you like to?
Yeah. I will go for progestins. Dynogest are very potent progestins. I feel that since she is in adolescent age, why not give her a conservative try? So we'll definitely go for a medical management, and Dynogest it gives very good result as far as dysmenorrhea and quality of life is concerned. Operative, because as you said, it's a progressive and chronic disease. Once you operate, you never know it will recur. So again, are you going to operate again and again? Why not give a conservative try?
Okay, so this is a question to Munjal again in the same line. That's
yes,
laboratory imaging parameters that you recommend to consider before choosing the line management of this type of endometriosis.
Yeah. So basically, she's 19 years old. Clinically, we may not be going ahead with post-speculum or vaginal examination. After consent, obviously, if she is sexually active, we can go for that if she is married. But if she is unmarried, we would majorly rely on per abdomen and per rectal examination. We would actually go for a clinical examination for finding out rectovaginal nodule. We would go for any adnexal mass that we may feel, and with concern with this laboratory parameters. This markers like CM125 is something which is not having accurate result because it may be rising in other inflammatory conditions as well. So that is not a reliable source. With imaging parameters, we would go for sonography, which may be repeated after 6 months. But in this particular Dr. Ajaywalia sir and Manoj sir said, we would go for after sonography, proper monitoring of every 6 months in the absence of any abnormal finding. We may continue with monitoring afterwards, but in case of doubt, we can go for MRI, and T1 weighted and T2 weighted images are something which would tell us that this is particularly endometriotic cyst, and it will rule out other adnexal masses like corpus luteal hemorrhagic cyst or even slightest chances of malignancy. And one more advantage of T1 and T2 weighted images of MRI are to have vision or even clue with regards to extra ovarian endometriosis. They may appear as hyper intense shadows on peritoneal or extra ovarian surfaces. So before proceeding with surgery, again MRI would be of great help. Obviously, laparoscopy is the final definitive diagnostic as well as therapeutic way with this particular patient.
Okay, sir. So Dr. Ajaywalia sir is here. So, would you say a good sonography is a fair enough investigation, or we should subject this 19-year girls for MRI at this point of time?
I would not subject her. My sonography is a quite good tool and a quite diagnostic. So I would not subject her. And postponing a problem of endometriosis in a young, we are going to increase or progress the problem, and she's going to land up in a frozen pelvis, and her fertility will be also a question mark when she reaches a marriageable age. So ideally, earlier you do, it is always better. The results are very good and the recurrence are very, very less.
We have got two school of thoughts, but see, conservative, the girl is 19 years, not desirous for concept. But Bakshi madam, you wanted to say something?
Yeah, I wanted to ask that with the conservative treatment, the currently available agents, are we going to stagnate the progress of the disease? That is the question. If yes, without destroying the ovarian cortex further, if we are going to bring about stagnation of the progress of the disease for young girl, I think that is the way to go. But to Vaibhav, I would like to ask, what do you feel?
I feel in this particular case, surgery is going to give her an immediate result. Where her complaints are dysmenorrhea, etc., she's going to get an immediate relief. Now the question comes, what do you do after that? Because you're going to solve her problem now. What's going to happen to her later? So the ideal thing is, if say suppose she is sexually active and you are able to operate on her, there is some way to bring about amenorrhea, say by putting an LNG IUD or by putting her on Dynogest post surgery, or even probably a GnRH analogs for a short period of time, which will bring about amenorrhea or stagnate her disease. This is going to help us two ways. One is that give her an immediate relief, and two, stop her from recurrence of disease for a period of time until she probably wants to conceive. Also, we've seen that AMH, etc., is 6.5, which is good. So I don't think even with surgery, you're going to destroy much the first time around. And what Juhi ma'am says is that she does want to try conservative management. You're going to have to use a really long-term management for her to have any sort of value for her. So if she's going to be able to live with her dysmenorrhea or with a pain, say for a while, then that's fine. But I would initially go in for surgery and give her something which will prevent recurrence in her.
Actually, I would agree with Vaibhav and Ajay sir, but yes, in a setup where the patient is not ready for going for the surgical option, obviously we'll have to respect. Then we have these options of combined oral pills, progesterone only pills, even GnRH agonists and
Dynogest if you're giving for a long time, imagine the cost.
Cost and the recurrence also can be.
Yeah, recurrence, and this is going to reduce temporarily. And her main primary complaint is pain.
Yes.
Pain is removed by surgery only. It cannot be removed by such a medications for a long time.
Experience. This is experience.
These are the proposed indications for resection of Dr. Juhi. You agree? You can read it out for us. That if a suspected endometrioma, when you need to do it is a rapid growth. Please go ahead.
Yeah, whenever there is a rapid growth or suspicious feature noted on ultrasound, there may be painful symptom that can be attributed to the mass, potential for rupture, and inability to access follicle in normal ovarian tissue. So yes, definitely, we have to resect this endometrioma finally.
Dr. Archana ma'am is.
Oh.
Ma'am, Sushma ma'am, you can take over now.
Yeah. Actually, the slides are in her hands. But I mean, the next question I can ask that if at all we decide to give Dynogest, then what dose and how long it should be given? Dr. Vaibhav, can you say?
Yeah, actually, if you start on her on Dynogest pre-operative, if you want to reduce the size or the complaints, you're going to have to start on at least 2 milligrams per day, give her a minimum period of 6 months to have any sort of beneficial effect. So, but once you do, say she does go ahead and take it for 6 months continuously, you will see a close to a 50% reduction in her volume and size of her endometriomas. Now, once you've done that, and probably then you want to operate on her, say in a younger woman, that will be the only advantage that we can get out of this, is because then you will be having a smaller endometrioma to deal with during surgery. If that is what you want to take out of giving her a Dynogest. If you want to give her a Dynogest before, that's the only option out. At least a minimum of 6 months to have any sort of beneficial effect. And if there are certain things, at least practically, that we've seen, even if you've given it for 15-20 days before her surgery, it kind of softens up the tissue before you're operating on. So maybe the dissection becomes slightly easier in these kind of patients.
So, Dr. Manoj, what is your opinion about the newer agents, cabergoline and letrozole?
There are papers where they have carried out the data for the use of letrozole as well as cabergoline separately for the treatment of endometriosis. As we all know that endometriosis is a estrogen-dependent disease, and estrogen gets converted from androgen by aromatase enzyme. Now, letrozole being aromatase inhibitor, it definitely helps to reduce the estrogen in the endometriotic tissue. And in endometriosis, when there is an increased expression of aromatase P450, which is being inhibited by letrozole. So letrozole, by reducing vascular endothelial growth factor plus prostaglandin E, it reduces in the peritoneal fluid. It definitely helps to stop the growth of the endometric lesion. But we should be worried with the prolonged use of letrozole, because it will end up with the bone loss, as well as there might be multiple ovarian cysts in the ovary if it is not associated, if letrozole not given with the OCPs or progesterone. When it comes to cabergoline being dopamine agonist, angiogenesis is one of the key features for the development of endometriotic lesion. Because when there is a angiogenesis, only then there will be initiation, maintenance, and spread of the endometrial foci. When cabergoline, being an anti-angiogenic factor, it will bring down the new angiogenesis through vascular endothelial growth factor receptor 2 inactivation, and it will reduce the microvessel density, which will lead to stoppage of the new developmental of the new lesion, as well as atrophy of the established lesion. So cabergoline, it is being given 0.5 milligram twice a week for at least 3 months, while letrozole, it is being given with OCPs or with progesterone continuously for 6 months. It has helped.
Yes, that is right. Actually, that Hamid et al., his paper says it's showing excellent results with cabergoline. However, there are not many RCTs. We need to wait for that.
I'm sorry for the network issue, ma'am. I'm back again.
It's okay. It's okay. For this case, the recommendation, Dr. Archana?
Yeah, ma'am, your slides are coming very small. Okay, can you make it on the show, ma'am? Okay, so here the panel, as we had Dr. Manoj Pandya putting up a very valid point, I could see that the clinicians to counsel a girl and her parents that the symptoms are presumed to be due to endometriosis, and we have to counsel that this is a long-term disease and will need a lifelong planning and treatment. Surgery should be avoided to diagnose endometriosis, but as we discussed in the worthy panelists said that if it's a pain symptom, we should always offer a surgery first to have the symptom free, and later on add something so that she has the disease becomes stagnant or gets delayed. At present, to empirically treat her for 60 days with adequate analgesics, combined COCs or progestins or dinogens for diagnosis and relief of symptoms. If the pain disappears, it confirms the diagnosis. This is the latest thing mentioned in guidelines. So I leave it up to the discretion of a laparoscopic surgeon and the sources available at patient's choice, whether they want to go for a conservative or an operative treatment. With this, I presume that everybody agrees. We will proceed to our case 3. Now, we touched the adult, then we touched the adolescent. Now I'm taking you back to the menopausal female who is 52 years and presented to us with a complaint of gradually increasing hirsutism and deepening of her voice. She had menopause at 40 years. She is hypertensive for 5 years and has a good BP control with telmisartan. She takes irregularly anti-inflammatory agents for osteoarthritic pain. And there's a significant history of PCOS in all her 3 daughters who are frequently consulting doctors over here. So on examination, you can see her BP is 140/90, pulse was good. Her face was plethoric and there was hirsutism, especially in upper lip, chin and upper abdomen areas. The Ferryman-Galloway score was 4. Abdomen and cardiovascular respiratory system were found normal. There was no clitoromegaly or temporal baldness. As her hemoglobin and blood parameters, 14 was there, hematocrit 54%. Testosterone was very high. As you can see, 2,540 nanomoles per liter. Her pelvic MRI, abdominal CT for androgen secreting ovarian tumor and adrenal tumors revealed that there was no adrenal or ovarian mass. So absolutely normal pelvic and abdominal CT. So in this imaging study, right and the left ovarian sizes respectively were 22/12 and 22/14, and adrenal configuration size was normal. So next one. These were the clinical findings, and now we proceed that how do we, ma'am, next please. So what is your differential diagnosis? And if we talk inheritance in family, and we'll come to that if PCOS inherited. So differential diagnosis, Dr. Manoj Pandya, would you like to answer this question? What diagnosis you start with this case, who is 54 years and had a menopause at 40 years?
She had because when PCOS is there with hyperandrogenemia during the perimenopausal or menopausal age, there are certain symptoms which are shared because of the PCOS and certain because of the perimenopausal age. When we think of the shared symptoms, they are the irregular period, infertility, mood changes, sleep disturbances, hair thinning, even weight gain also. But there are certain features which are peculiar to PCOS, say like acne, pelvic pain, or maybe skin.
Do you make any differential diagnosis at this point of time before thinking of the overlap of symptoms?
Maybe hyperandrogenemia due to PCOS, and maybe androgen secreting tumors might be of adrenal origin, or any medication which patient is using, which may give rise to such androgenic features.
So now this case had a link, the daughters are suffering from PCOS. So is there any inheritance in the family, Sir Ajay Walia, sir? And
see, PCOS as such there is a genetic predisposition.
Yes.
So there is no doubt there is an inheritance link. I just wanted to ask, did she have such symptoms before she stopped menstruating, like hyperhirsutism and all those things?
So she doesn't tell anything about this, just irregular, sometimes irregular cycles, but otherwise
no.
Because
without any tumors, either in the ovary or ovarian size, which is extra large, or a stromal thickness is more. In fact, postmenopausal, the ovary should come down in the size.
Exactly.
And without all these things, and she never had such symptoms before, there is either some extra medications she's doing, or I need to have detailed evaluation of cortisol stimulation test, testosterone, DHES, and all those things before reaching a particular diagnosis, labeling this only because of PCOS.
Yes, so we have to rule out.
In her obstetric history, you told she has 8 children.
Yes, no infertility, sir.
No infertility.
So this is the inheritance. If we just sum it up, that 20 to 40%, there's the first degree relative is there. So Manoj sir, you were talking about the similarities of the symptoms. So we can go to the next, madam.
Should I repeat it, or yeah, okay.
Yeah.
I already delineated it.
So unwanted hair growth, face or chest, weight gain, these are all similarities. There is a difficulty in sleeping and mood swings, with most of us observe, husbands especially, and irregular missed periods. So next please, so what is the differences you would see, Dr. Juhi? How would you differentiate rather? Talking about the perimenopausal symptoms and PCOS.
PCOS symptoms, there will be sudden increase in central obesity. There can be, due to PCOS, and in perimenopausal age group, of course, the mood swings and all will be there. And in PCOS, other than that, glucose intolerance will be there. We can go for certain investigations. We can see whether there are signs of insulin resistance in that cases, and of course hyperandrogenism, features of hyperandrogenism. As you said, this women had excessive facial hair growth. So these are all signs of PCOS, hyperandrogenism. And talking about perimenopause, more towards mood swings and hot flushes approaching menopause, and also menstrual disorders. So this is how we differentiate that. These are some of them. Those are the symptoms of perimenopausal age group, and others are of PCOS.
Yeah, and I remember Ashi's first slide, what is the skin condition? So these are few skin conditions which indicate? I would not answer the
and
question.
recurrence of acne at times in
Yes.
perimenopausal age group. कि मैं तो अभी वापस से I am getting younger, I am getting acne.
And there are certain symptoms which are very unique to perimenopausal changes. Dr. Vaibhav, would you like to take that question?
Please unmute.
Sorry, I was muted. Okay, so yeah, with complaints to perimenopausal, there's symptoms like night sweats, hot flashes, which are quite unique to perimenopausal women. They have decreased decreased in libido. They have complaints that they have usually urinary tract infection, or probably in these patients who have vaginal dryness, painful intercourse, are those kind of problems that are usually unique to perimenopause rather than that with polycystic ovarian syndrome.
Overlapping symptoms we can differentiate with these few differentiating characters, as Dewey already said about the hot flashes and night sweats. So how does menopause affect the polycystic ovarian syndrome? Dewey, would you like to take that? If a lady is suffering from PCOS, so how does the menopause affect, or what changes would you have in mind?
Dr. Chui, you have to unmute yourself.
Yeah. If the woman is approaching menopause and she has PCOS, in that case, such women may have delayed menopause. So the menopause usually get delayed for about 2 years, and also patient will have all the signs of hyperandrogenism, risk for coronary artery disease, metabolic syndromes will be more. So in that case, if the patient, as in this case, the daughters also had PCOS, and this woman has features of hyperandrogenism at this age. So these women should undergo all the investigations so that her metabolic syndrome may be confirmed and she can be treated for that. First thing. And second thing, such women also have risk of endometrial CA. So in that case, you should go for a proper scan and also endometrial thickness in such patients.
So once a PCOS, it was not going to go away, and we have to be very careful for first 5 years when we are dealing with a history of PCOS in a perimenopausal female. So the another question is that now, how does the PCOS affects the menopause? Dr. Munjal, if you are still with us.
Yes, ma'am. Basically, as Madam earlier discussed, PCOS has metabolic syndrome associated with it, insulin resistance, dyslipidemia, and obesity. These are some of the features we usually see with PCOS, and they continue to stay there at least for a longer duration. And this longer duration of metabolic syndrome or unopposed estrogen effect does have its effect in form of diabetes, hypertension, and dyslipidemia, ultimately increases chances of cardiovascular risk. So this is ultimately we see in this women.
मैंने एक आपको WhatsApp किया, वो देखो तो वो वाला चलेगा
क्या? As compared to those people who are not having PCOS.
Yeah. Very rightly said. So, Yuvraj, this type of patient once comes into your OPD without any symptoms, the perimenopause, what is the line of investigation would you advise to rule out any further complications, and when are you going to call her for follow-ups?
Yes, ma'am. Ma'am, if I'll take a minute. So I had an opportunity to address this group of patients with a group of endocrinologists recently, and interestingly, this group of patients have been labeled as postmenopausal hypoandrogenism, and under that they have put two categories. So one is ovarian hypertrichosis, and that ovarian hypertrichosis is basically the patients that we are talking about. That is the patients with PCOS who have carried androgenic status in their menopausal age. And that's what Ajay sir was talking about, that these are the patients. So when coming to the question, how do you diagnose them? So these are the patients that after doing an MRI and after doing your hormone analysis, your MRIs are going to come normal as it has come in this patient one. And secondly, on ultrasound, you're not going to see a postmenopausal ovary. You're going to see an ovary that is normal in size or probably larger in size with a stromal, hyperechoic areas with decreased vascularity. Now, in case you have an increased vascularity in same kind of ovaries, you again think towards the tumor side of it. So this category of patient is known as ovarian hypertrichosis. And the second category that they have divided is an androgen secreting masses. So concerning these patients, of course, you need a testosterone level, a DHA level, and androstenedione levels, apart from your ultrasound and an MRI if you're suspecting a mass. These patients will have increased testosterone, but their androstenedione levels will be normal because you're also trying to rule out their adrenal causes.
Very, very nicely answered that, Yuvraj. And Dr. Manoj, would you like to add something to that? As Dr. Jui was saying that let's equally follow up for endometrial.
Now, with regards to PCOM appearance, sometimes in the perimenopausal or menopausal lady, if there are the ovary which are looking like PCOM, maybe due to inclusion cyst or maybe due to the vascularity problem.
Thank you for bringing up that point, sir. So this patient, the particular case which I was dealing with, she was admitted, shows gradual decrease in level of testosterone. Say within 5 days, we had a normal level. So now what do you suspect in this patient? I think Dr. Ajay did hint in the starting point. So the twist in the story is that the patient was showed that he was using transdermal testosterone gel since a year for impotence, and he misguided her wife that it was for the painkillers. So she was using it for her osteoarthritis treatment, and this transdermal gel used unconsciously for the knee vein for 6 months brought about this hirsutism. So we should be very precautionate that twist can happen. So husbands need to be counseled, and the history digging is very, very important. So
history is very important.
That's amazing.
That is very interesting. Very interesting.
So
Archana, there is one more interesting logical thinking which I am going to discuss this. See, usually post-menopause, the ovaries are small and the estrogen secretions are less. Yes. But compared to that, the androgen secretions are a little more. So androgen-estrogen ratio reverses. So in the menopause age group, you do find little hair here and there, which she never had before. So androgen in that particular level, androgen-estrogen level in a regular normal patients will be reversed. In PCOS, this does not happen, because estrogen levels are relatively still higher and estrogen androgen level is not that increased. This is just a logical thinking. Second thing is, for mood elevation also, there are certain doctors who are giving androgens.
Yes.
So that also has to be kept in mind.
Yeah, sure. We should take it as a take-home message. So this twist,
and even it takes 20 years for testosterone to come to normal level even after menopause. Many a time, and testosterone is higher for almost 15 to 20 years after menopause.
Next one.
Like this was a combination of hirsutism, which otherwise would occur at menopause, also added PCOS, and then one was clueless, like what it could be. Very interesting.
I just want to interrupt, ma'am. If at all we encounter such large ovaries and the patient is approaching menopause, we should definitely go for endometrial thickness so that we can rule out other pathologies, and we can go for endometrial biopsy, say a pimple biopsy in such cases.
Exactly, that is what I said. We have to call her for follow-up. That is very important because of bulky ovaries. So this was a case where the clinical analysis revealed high level of testosterone, and pelvic MRI and CT were normal. But here, as Dr. Jui is saying, that we should always have a follow-up protocol for these patients, and endometrial thickness should be monitored.
But so usually such a large ovary and 10 years of menopause, if there is a very active ovary, it should always have a breakthrough bleeding or a postmenopausal bleeding.
Yes, sir. So, this patient was found to have iatrogenic hyperandrogenism, and this condition is rarely reported cause of viralization. So postmenopausal, this is now evident that PCOS doesn't disappear as women get older, and reproductive hormones in women with PCOS differ from those in women, as Dr. Walia and Dr. Pandya sir very nicely explained. And I really like the way Yuvraj put up the ovarian changes. They were very good take-home messages. And most importantly, inflammatory and metabolic parameters worsen with age, putting women with PCOS at increased risk for lifelong health hazards, especially the risk of developing CVD, type 2 diabetes. So careful history and getting correct perspective. In my case, the husband's perspective was not known to us, and help us to diagnose the case. Next, please, ma'am. So the take-home message for the case of endometrioma, the presumptive diagnosis of endometriosis based on symptoms and clinical assessment is enough. I think we have gone through this, so we can skip this. We already discussed at length. And reports of
Sure.
menopause over the should be very carefully evaluated. And in the today's light, when we have got a better diagnostic methods, we should also always focus that the history and physical examination still is a golden standard to rule out many things. So I would recommend strongly that couple should be present when you are taking the history, so that something is not missed out, as this innocent lady in our case. So in the pandemic era, soap and water or common sense are the best disinfectants available nowadays. And we really had a very good amalgamation of thoughts with all the esteemed panelists, and it was a very, very happy moment to moderate it with Dr. Bakshi Madam, though some technical difficulties were there. But everybody gave their inputs, and it will give us a long-term take-home messages, crisp take-home messages, which will help us in our private practice. And
thank you very much.
Thank you.
Thank you, ma'am. Thank you very much.
Excellent panel. Thank you, Dr. Archana. Thank you, Doctor.
Thank you. Thanks to all the panelists and Archana for taking out all such nice cases. Pleasure is all.
Thank you, madam. Thank you, Archana, madam.
Thank you,
Sushma,
ma'am.
Dr. Sushma,
I
and
was
Dr.
so
Archana.
fortunate enough to be part of this panel with
But
such
you
so many
are working
stalwarts.
in a government setup, and that is a real wonderful experience. And sometimes we need to have those inputs, because everything cannot be very lavish with all the gadgets around. So sometimes we need to go to the roots to get hold of the things in a better way. So it was lucky to have you here. So Ashish is waiting, and I think everybody is waiting for the answers. So I'll not
Thank you so much. Thank you so much.
Nice panel discussion, madam.
Thank you.
Thank you, Manish sir.
So we
Nice
have got
to see you
M
after so
Pandya
long.
cube. Now you see M Pandya cube is there.
Manish bhai, we missed your inputs.
No, because I was there continuously with the panel, but I was not supposed to interfere. Otherwise, I would like to have inside the popping everything. But thank you Archana for involving all three Pandyas here.
I like to raise my. I was previously before marriage. I was the Pandya only, so I come to the class.
Oh, wow! So there are 4 Pandya.
Yeah, 4. You can include me in. So Ashish, up to you now.
Thanks to Sushma.
Thank you so much, Archana ma'am. Thank you so much.
Taking up instead of Sonia, and very nicely conducted, both of you and all panelists. Manoj, Jayvalya, Yuvraj, Juhi. And Munjar and all others, very nice, excellent.
But please tell Dr. Sonia that we missed that.
Yes.
I will.
Thank you, Sushma ma'am. Thank you so much. Thank you, Kanti ma'am.
My pleasure.
So here are the answers to the quiz. Ashish, would you like to announce the winners?
Hello, everyone. So it was really a wonderful session with wonderful talks and an excellent panel with great cases. I'm sure we have wonderful take-home messages. Just a quick overview of the answers of the quiz today. The first picture was obviously of Acanthosis nigricans. The person who contributed not to the treatment but to the invention of PCO was an Italian scientist by the name of Antonio Velesneri. The month when we celebrate PCOS is September as an awareness month. Robert Benjamin Greenblatt identified, or rather invented, clomiphene citrate for use in PCOS patients. Premature androgenetic alopecia is the answer, or is an equivalent to the PCOS in males. Obviously, Rotterdam criteria, or I would have accepted Androgen Excess Society criteria as well. Any of that was the correct answer. Reclining butterfly pose or a Supta Baddha Konasana was the yoga asana for treatment or maybe a relief from the PCOS. Steen and Leventhal are 2 scientists who originally did the PCO puncturing technique. They did a wedge resection, as we all know. This picture was only of Edwin Steen Freller. Leventhal was not there in this picture. in context to womanhood, PCOS is called as a thief of womanhood, as it takes away everything that describes womanhood. And Story Time with Sonam Kapoor is her Instagram series of videos where she keeps on spreading awareness on such medical issues. So with that, thank you so much, everybody. Have a wonderful evening.
And answer
Very
winners,
nice
please.
quiz.
Ashish, would you
I
like
have
to
to
announce the winners?
I'm sorry, I'll just do that.
Yeah.
That's very important. People are waiting.
Yeah.
Yes. Just give me a minute. Is my screen visible there?
Yes,
yes.
Okay. So we have an interesting result. I and Deepa did a very important job of finding out winners in between. And interestingly, here is the list of winner. My screen is not moving. Yeah. Here is a list of winner. So the second runner-up is actually a tie between three members. That's Dr. Janki Pandya, Dr. Varsha Prapanna, and Dr. Yuvraj Jadeja. The first runner-up is Dr. Shonali Agarwal, and winner for the quiz with maximum correct answers are Dr. Himani Patel and Dr. Saloni Prajapati. Congratulations to everybody. And everyone had a wonderful participation. I'm so happy to see so many answers on my WhatsApp. Thank you so much.
Thank you, Ashish, for wonderful quiz.
Yes, sir. Yes, Manish.
Dr. Yuvraj is a multitasker. Huh?
Yeah, even Janki needs an applauder. Munjal, I'll convey that to her.
Yes.
Thank you, ma'am.
Thank you, ma'am.
And let me tell you, when Ashish conducts the quiz and you win, that feeling I have, I won the first prize along with Preeti Niranjan ma'am. So, like, yes, wow.
Thank you so much, Ashish sir. It was wonderful quiz, and it is such an innovative idea to have this quiz in between sessions, madam. So heads off to BOGS as well, ma'am.
Yeah,
very nicely conducted. Very nicely conducted program.
Audience
selection of
chewing-gum
questions
quiz.
were excellent.
Thank you so much. Thank you, everybody.
It is a Ashish audience chewing-gum quiz because people can chew over there, so they will remain there because something poppy is coming out.
That was the whole idea of it, sir.
Yeah.
Very nicely conducted.
Manish, so happy to see you.
Thank you, Sushma madam.
Yes, मनीष कितने पॉपुलर हो यार मनीष
हाँ
बहुत पॉपुलर हो यार
मैडम आपका कलीग हो ना आपके आशीर्वाद से पॉपुलर हो गया
नहीं sir is very nice. I mean I remember sir before 4 years back he came to Bhopal and I remember Bhopal.
अरे एक बार मिलते हैं तो भूलते नहीं है उनको कोई
बिल्कुल सही
सच है
और भूलना चाहो तो हम भूलने नहीं देते
The last word is his. हम लोग नहीं बोल सकते वो ही बोलेंगे लास्ट में So thanks to Archana for all this.
Thank you so much.
Thank you. Like extend my thanks to Dr. Kanti Bansal ma'am first of all for being the backbone of this program and arranging.
Statue क्यों हो जाते सब? Statue हो जाते सब?
नहीं मैडम ये कैमरा ऐसा दिखता है आपके सामने सब लोग स्टैच्यू हो जाते हैं
हो जाते हैं
Like it.
Adorable Kanti ma'am, that is what we say. So thank you, Kanti ma'am. Thank you, esteemed faculties, everybody for making this program a real take-home feast for all of us, and especially Walter Bushnell team also to conduct it so well, and they have been our academic partners, and really we have gone a long way, and every time we are very, very thankful for a flawless program. And Dr. Ashish and all the audience and participants for their enthusiastic participation in the quiz. And Deepa, Amrita ma'am, Dolly, I think everybody is busy running around, but everybody was there. So thank you everybody, Yuvraj, Dr. Pandya. I mean, I'll say 4 Pandyas, that would be enough.
Thank you.
That would be enough.
We are happy to include one more in the family.
So
thank you, ma'am.
Ma'am, thank you for the wonderful opportunity. Walter Bushnell always stands committed for any kind of scientific piece. We'll be always associated with you.
So nice.
Thank you.
Thank you again. And we have started with the note of rest in peace. Still, the whole two souls will rest in peace.
So in this, stay healthy, stay safe. That is the main motto for all of us. Thank you.
Thank you.
Good night.
Have a great evening ahead.
Thank you so much. Okay. Bye-bye. Have a good day ahead. Thank you so much.
Good, Yogendra. Thank you, ma'am.